Okay, I think we'd like to get started. Can we get started, you guys? Hi, would everybody have a seat? Wow. Excuse me. Dr. Yagoda. Dr. Yagoda. Sit down. Thank you. Good afternoon. Today is March the 6th, 2024, and it is 1:01 p.m. As a quorum of the committee is in attendance, I would like to call to order the meeting of the Central Health Strategic Planning Committee. As a reminder, a committee member may also be participating by video conference, so the staff will be managing video and audio feeds of all participants closely to make sure we have a legally compliant meeting. Due to technical difficulties, today's Strategic Planning Committee will not be live streamed on YouTube. So if you're listening, you can still view and join the meeting on our Zoom link, which is posted on our website at www.centralhealth.net. Today's meeting will be uploaded to our YouTube channel as soon as possible. Thank you. So the first item of business is public communication. Members of the public who wish to make comments virtually during the public communications portion of the meeting must have registered with Central Health via the online form or by telephone no later than 11:30 a.m. today. Yesenia, did anyone register to make comments for the Strategic Planning Committee meeting? Thank you. And we will now proceed to the committee agenda. Item number 1, review and approve the minutes of the January 17th, 2024 Strategic Planning Committee meeting. Do I have a move? So Manager Matwani approved the meetings, and the second was with Manager Kitchen. So item number 2, receive. Oh, a vote, please. Oh, yes, okay. Everyone vote.
Aye.
Aye. Okay, thank you. And Cynthia, thank you. Receive and discuss an update on Central Health's communications, engagement, and outreach efforts, including an update on the unified branding for the Central Health system. Ted Burton, Ivan Davia, Isela Guerra, Mike McKinnon, and Anastasia Sims will be presenting. Thank you so much. We're all so excited to hear what you guys are going to tell us.
Okay, good afternoon, everybody. I'm Ted Burton, Chief Communications Officer with Central Health. I'll let my colleagues introduce themselves. It's a big group today.
Isela Guerra, Senior Manager of Community Engagement and Outreach.
Ivan Davila, Senior Director of Marketing and Communications.
Anastasia Sims, Content Manager.
Mike McKinnon, Senior Communications Manager.
Okay, cue the balloons and the confetti gun, Edwin. Oh, wait, we didn't get that. I'm sorry. My apologies. We're really excited to bring to you today an update on our communications, community outreach, and engagement efforts for the first quarter of fiscal year 2024. This is going to be a regular update every other month to this committee so that you consistently are hearing about the work that we're doing. And today, I'm very excited to bring to you an update on our branding initiative. As you'll remember, next slide, please, way towards the top. Next slide. Back one slide. So you remember in December, we came to you with an update on the unified branding system. It was in black and white, and we know that you like things in full living color. So today, we're bringing to you the branding suite in full living color. Next slide, please. This is it. So after the December meeting, we continued the color exploration and working with our partners at Sendero and Community Care. We actually presented to the Sendero board and the Community Care board in January. And I want to especially thank Sharon Alvis with Sendero and over at Community Care, Tara Trower and Jason Fournier for their support in helping us bring this vision to fruition. Both entities approved the branding system and logo. As a quick reminder, it was back in 2018 that the Germain Solutions independent third-party performance review, one of the many findings of that organizational performance review was regarding our unified branding system, that people in the community don't know who is part of the system, how we're connected, and the value that we bring to the community. That led to a lot of research. Then there was that pandemic that we all experienced, and we put this on pause, and we restarted or jump-started the initiative in 2023. And again, we conducted more focus groups with staff, non-managers at all three affiliates, patients, non-patients. We did in-depth interviews in languages other than English and Spanish, and surveys as well. And that's how we landed here. You've seen the logo system, you just haven't seen it in color. Just quickly about the color, this is not actually the color. I'm sorry, this is because it's a giant screen and a projector. The colors are actually a really dark green and a mint green. I can show that to you, so don't be fooled. It looks, at least to me, it looks light blue there. But what you do see is that we've unified the logo system with two colors for all the affiliates so that we all share the same brand equity and credibility across the network. We chose the dark green, light green for specific reasons. This is based on what we heard from focus groups. They told us that blues and greens were just more calming and trustworthy, and it's also why you see those colors oftentimes in the healthcare space. And these colors also were built with ownability in mind. And so we've looked at them, all the affiliates in market against competitors or similar organizations, and they really stand out. And then I'm going to go into the next slide. Across the top, and I'll show this to you in full page in a second, is the color palette. Do you mind going ahead and going to the color palette? Next slide, please. This is the color palette. Again, it's deceptive on this large screen, but you'll notice on the far right is that community care legacy orange. That was really important to community care, and we wanted to ensure that they don't lose that just because we have two colors in the brand that are not orange. Personally, I wanted burnt orange, but that got killed by a few people. I'm kidding. But this orange is going to be a primary accent color, and so you can see here the color palette. Next slide. And you can see what that might look like on a website or perhaps in an annual report. All the colors are there, but what looks gold here is actually that community care orange is a highlight or accent color to really make things pop. Next slide. And then just on some other platforms, top left is what a website home screen or homepage might look like. Top right, perhaps it's a print advertisement or some sort of a collateral piece. Bottom right, most folks access us via their mobile devices. So this is what the homepage could look like with an advertisement on it on a mobile device. Oh, that's okay. And then bottom left is just a business. Can you go back one slide? Bottom left is a business card. I'm not sure who that person is, but we would create a whole business suite, business cards, badges, letterhead, etc. Next slide. And I'll just do a quick update on the timeline, and we'll go into much more detail at our next meeting. We previewed the brand system at our all-staff meeting on Monday. Next month or two will be all about brand development, a really detailed communications plan that we're collaborating with community care and Sendero, an implementation plan, all of the things that you can imagine from building signage to business cards and everything in between. And then we're looking towards, with community care and Sendero, a brand launch in May. As a reminder, May is the 20th anniversary of Central Health, so all of the timing is really fits together very nicely. And then we think it'll take about 2 to 3 years to fully implement and integrate the brand across the entire system. Next slide. One quick note. You'll remember we presented this to you, I think sometime last year. We led an effort with Travis County, Austin Public Health, the District Attorney's Office, and Integral Care, and our ad agency, Belmont Ice House. They've been our partner for many years, have worked with us on branding and also an opioid crisis awareness campaign called One Dose, It's Over. We created the Austin Travis County Opioid Awareness Coalition. Those are some of the advertisements that you may or may not have seen in market. This campaign just won an Addy Award, which is a very prestigious advertising recognition, a statewide award. So I wanted to give a shout out to our consultants because they are amazing and trusted partners, and the team for bringing this to light. And most importantly, hopefully we're helping save lives. With that, I'm going to turn it over to Isela.
Hello. I'm going to talk about our engagement and outreach efforts in the first quarter of FY24. Next slide, please. So just as a reminder, our objective in outreach is to help residents connect to coverage and care. And we continue to focus on Travis County's most vulnerable residents with low income through grassroots efforts with our own staff and with our trusted partners of C2H. Next slide. Our outreach strategy is to meet our potential members where they are, whether that's at a church, a neighborhood center, resource events, or at partner organizations. We have community health workers on staff who provide peer-to-peer navigation for the medical services and system and education on coverage programs and other resources in the community. We offer them application assistance, so whether that is helping them submit an online application through our website or using the point of service application, which is specifically for our unhoused residents, we're able to help them at the library, at different organizations where they already are, and try to keep them from having to make them come to us. And as well in the community, we are providing general awareness, grassroots efforts, word of mouth, messaging about MAP, the different services and programs that are even coming online as we speak here at Central Health. Next slide, please. So here's just a quick snapshot of the reach. This actually goes from the October 1st through the end of January, so it's a little bit more than the first quarter. But we were able to interact with 5,893 residents here in Travis County. Those may have been people that we met at an event, that we helped submit an application for, that we, answered questions or helped provide a resource for. The application assistance, we helped 98 people apply, and we were able to confirm that 88 of them were successfully enrolled in the Medical Access Program, MAP or MAP Basic. Next slide, please. Okay. And in community engagement, just as a reminder, our goal there, next slide, please, is to educate MAP members and the general public about Central Health's functions, how we operate, how we pay for medical services, our healthcare equity implementation plan, and budget priorities for the next fiscal year, as well as gather their input to help kind of direct our initiatives and the way that we're going to be providing services and budgeting. Next slide, please. The tactics that we use in community engagement include the Community Health Champions program. That's a program that builds strong relationships and a deep understanding of Central Health to people who are healthcare advocates or interested already in the healthcare space. And additionally, we have a spin-off program called the Accelerated Community Health Champions that I'll talk more about in just a moment. But that brings in our MAP member Medicaid recipients into this educational opportunity about the benefits and the services that are available here. Community conversations, we try to hold those not only here at Central Health, but we also take those out into the communities that have the highest concentrations of either families living in poverty, of MAP members or potential MAP members. And we do that very intentionally to try to, again, meet people where they are and not create a barrier for their participation. Our listening sessions are essentially taking some of this information out to neighborhood associations, such as in the format of a meetings in a box exercise, or just an opportunity to really talk about some of our initiatives and then get feedback from the individuals, primarily who have used the services or will be using the services. And then we also do interviews and surveys, a lot of the time by phone, not only intercept, because we want to make sure that we're hearing from everybody. And we know that to really hear from our members, sometimes we have to pick up the phone and call them individually to get their input, because we may not always run into them at an event or at the Health and Wellness Center, or anywhere else like that. Next slide, please. So a quick snapshot on our engagement work, and again, this goes from the 1st of October through the end of January. We had 105 participants in our community conversations. The last ones were in November, and they were about our CEO candidates. We also have graduated a class of community health champions in December, and that makes our total community health champions since 2016 361 strong. So there are a lot of people out there supporting us and helping amplify our message, but we can always use more. And then a list of some of the community meetings that we attend regularly are listed up here. I won't read them off to you, but I will say a little bit more about our Accelerated Health Champions program. As I mentioned, that is a kind of a spin-off off the Community Health Champions, and it's very tailored to specific neighborhoods. So last year we were able to implement one in the Runberg area. Just yesterday we started the program, which consists of 2 workshops in the St. John's neighborhood. It's completely in Spanish, and all the registrants, all the participants are monolingual Spanish speakers. And we're gonna be introducing this. We're already recruiting for the program in Colony Park. What makes it specific to the community is that we really focus on the resources that are available in the community, whether they be central health resources or other partners' resources. And then we, of course, let them know about the benefits that are available to MAP Basic members, as well as the services provided at our health and wellness centers. And then next slide, please. And then here is a high-level overview of our engagement cycle. You'll see that there are the Community Health Champion programs are on there, as well as our planning. We have, of course, the Latino Family Support Conference that we're planning for, and we will be creating advisory groups for that soon. And then, of course, we continue to invite and inform members of the public, MAP members, about these meetings and about the opportunity to come and share their personal stories with all of you. And with that, I'll pass it over to Ivan.
Thank you, Isela. All right, so in quarter 1 of fiscal year 2024, our advertising efforts focus primarily on the Affordable Care Act open enrollment period. So our objective was to promote awareness of the Affordable Care Act Health Insurance Marketplace open enrollment period, motivating Travis County residents to take advantage of free enrollment assistance. And it was a multimedia campaign, and this included grassroots outreach efforts, including outreach strategies such as those that my colleague Isela Guerra was just sharing with us, organic social media. This is our putting social media, posting on social media via our own channels and our own content, and then also earned media or media relations, partnering with members of the media to share information via their outlets, and then of course paid media. The paid media campaign ran from November 6, 2023 through January 14th, 2024, coinciding with the open enrollment period. Our paid media tactics, including streaming video, online video, streaming audio. Streaming audio is if you have a free Spotify or a free Pandora account and you are listening, you get some ads. That's what streaming audio is for those who have free accounts on Pandora and Spotify and others. Then we also included Spanish radio ads, streaming display, and social. So these paid media tactics were chosen based on high index against our target audience and historical performance, which means that we use paid media best practices, and we identified the tactics or communication channels that are a great majority of members within our target audience use to consume information. So that's how we pick these tactics. Next slide, please. So you see some of the creative here on the screen, some of the creative that we used. Every piece of creative and communication was in English and in Spanish. And we leveraged our own visual standards while bringing in branding and thematic elements from our partners. And you can see, for example, in the left and center columns, we use Central Health's own photography while incorporating Sendero's branding and their 4-star graphics. And then, as we do every year, we partner with HAM to promote our premium assistance program among us and musicians. In all of these cases, we created ads that were distinctly Central Health, but that were flexible enough to accommodate complementary branding from other partners as well. Next slide, please. So this slide shows the progress that we made from last year's campaign to this year's campaign. You can see the difference from 2023 to 2024. On the left-hand side, we show impressions, and this campaign garnered 10.7 million impressions. So an impression, so the impressions is the number of times people see our ads. One person can see an ad multiple times. So this means that that our ads were viewed 10.7 million times in 2024, which was a 75% increase over the 2023 campaign. On the right-hand side, as we do with everything that we do through communications and also paid media and anything that we share via our communication channels, the call to action is to send people to our website to learn more. And they can access the information via their mobile devices or however they access the internet. And you can see that the increase, a 177% increase in the number of landing page views from last year to this year's campaign, with 4,600 landing page views. And with that, I'll turn it over to Anastasia.
Yes. Okay, next slide. Yep, next slide. Thank you. So as we know, Central Health's patient population skews at adults making less than $30,000 a year, as well as about 60% Hispanic Latino. This statistic shows the share of adults using social networks based on income, so that you'll see that 69% of adults making less than $30,000 a year use social networks. In addition, according to other research, about 85% of Hispanic Americans use social media to some extent. That's self-reported. So basically, this slide is just telling us that we're using social media as a key communications channel because our patient population is there, according to studies and surveys. And this is all in addition to what Isela was talking about with outreach. Next slide. So Q1, our post reached about 5 million users on Facebook, X, Instagram, and LinkedIn. Keep in mind that we run 7 different platforms. We have 4 Facebook pages, one for the main Central Health brand, one for the Hornsby Bend Health and Wellness Center, one for the Northeast Resource Center, and one for Southeast Health and Wellness Center. And all of those brands have different, well, not brands, all those different sites have different targets. So we target mostly by location, but also income, also the people that come into the centers, what they look like, what their needs are. And that's how we kind of cater the content. Our engagement rate was about 36,000 just for Q1. And again, engagement is the measurement of all interactions. So like a retweet or a comment or link clicks or even mentions. Engagement is really our bread and butter. Next slide.
Next slide.
So this is how many times we posted per platform. Again, we have 4 Facebook pages, 2 Instagram channels. Hornsby Bend has an Instagram, which we are testing right now for our other sites to see if they need one. LinkedIn, we only operate 1 right now. There's further exploration with that also. And then X. And you can see the numbers. Next slide. I'm going pretty fast. Next slide. And these are just the video views. This is important because we get YouTube is not there where this meeting would stream, but a lot of our organic posts get the most views from Facebook and Instagram. And that is all I have. I'll pass it to Mike.
And we can go ahead and jump to the next slide. So I'll be covering our website and how that ties into everything else. And I did just want to draw some attention, based on the most recent information we had. This is sort of a combination of census data as well as Nielsen data from some partners. But as you can see, essentially everyone in Travis County at this point in time has internet access. But what's interesting to us is as you break it down, federal poverty level, it's about 97%, federal poverty level, 200%, English, 96%, and then federal poverty level, 200%, Spanish speaking, about 98%. These numbers continue to go up every year, which is why we are very focused on digital. And this will be a topic of conversation later, but just comparing it to what you would call traditional cable TV subscriptions, how much higher those numbers are in every category. And then also, comparing YouTube viewing to cable television access is also really interesting to us because, of course, we do use YouTube for streaming our meetings. And I did want to draw attention to the fact that we have been partnering with DECA, which is a local community group, as well as Austin Freenet to have them table at our events. Really great partnership. It helps people without internet access, without hardware even, to be able to get that access, to be able to get computers or mobile devices or whatever sort of device they need to get online. And so they've been tabling at our events and been really helpful for our patients. Next slide, please. And this is just a snapshot of the past year. These are visits to our site. And what's interesting is I don't want to call it a relaunch, but we did have a bit of a reskin of our website. We became much more patient focused in our navigation and the way the site was organized in roughly it was September of last year. But you can see there's so much more interest in Central Health around our budget season. But even after that, our numbers have increased. So daily users prior to that line of demarcation, 640 average a day, and then after 778 average a day. So we're increasing the amount of traffic, and I think that is in no small part due to the redesign of our site, but also what Yvonne was saying earlier, driving traffic to the website. We want to drive people who are interested in learning more about whether it's ACA or MAP eligibility, about services that are available to MAP and MAP basic members. So we're driving people to the website, and that's really reflected in these numbers. Next slide, please. I won't spend a whole lot of time on this. I did already cover sort of the average users per days. Engaged sessions, Anastasia explained what engagement meant on social media. On a website, it's basically how much time they spend on the site and how much do they click. And so the number of engaged sessions on our website is actually incredibly high. I think the average is somewhere around 60-something%. We're at 93.5%. That means that people are visiting more than one page. They're spending time on the site. I think you bounce off a site if it's less than 15 seconds, more than 15 seconds on a site, more than click on one page, you're an engaged user. The other interesting thing here is our top 10 pages. The MAP eligibility page is consistently our number one. But if you look, the entire website is in English and in Spanish. And so the MAP Spanish page is our third most popular site after the home page. There's quite a bit of provider-specific content on there as well. But then if we go ahead and jump to the next slide, I think this will kind of show, this is how people land on our site. Organic search means people are going to a search engine and they are typing some keyword or phrase. In our case, the number one phrase is MAP insurance. That's what people are searching for. And that is driving people to our website. The majority of the traffic, more than 50%. Direct means that they either have the site bookmarked or they are typing centralhealth.net because they've seen it on a sign or they've seen it on a billboard. Referral traffic is important because that means those are our partners or people who, community care, they have links on their website. It's the city, it's the county. So they're driving traffic to us. Display and paid, those are our paid campaigns. Organic social, whenever we post something on one of our social channels that says visit centralhealth.net to learn more, it's a call to action, and that's what's driving people to our website. And you can see the numbers are, the ratios are pretty consistent. But I will say that over 50% of traffic being driven by organic search is considered optimal. We're at about 54%. That tells us that our search engine optimization is working, that we are helping people find us through the content on our website. And then I think we have one more slide.
Go ahead.
Okay. And I know this is also another topic for another meeting, but we did just want to point out that we are, committed to transparency. The website is constantly evolving and changing. We did make the meetings more obvious, easier to find by adding that to the top level menu. And then also we just sent out, hopefully you received it yesterday, an email from Dr. Lee, our CEO, about our 2023 financial audit, our clean finding there. And then we're also including information about the board meetings, how people are able to sign up to speak for public communication, and that's going to be part of a larger ongoing campaign.
And it was also on social media. We also shared it on social media.
We're going to bring that back to you at the executive meeting on March 27th, more about promoting board meetings, et cetera. So I think with that, we're happy to take questions. Thank you for your time.
Thank you so much. Now, does anybody have any question? Yes.
I do.
Oh, okay, so just wait. Manager Musaitif is asking a question first.
No problem.
Well, thank you all. Thank you to the Dream Team. You always deliver. Appreciate all the work that you are doing. I also wanted to share something in terms of outreach and reaching out to others. Your work apparently has interested many individuals globally. So several are reaching out to me during their time traveling to South by to come and visit Central Health and learn about the work we're all doing. So on Friday, there will be a visit here with some folks to learn about what we do. So again, thanks for all your efforts. I know efforts are, I always say, act locally but think globally, and the work that you do can inspire others, but also we can learn and exchange knowledge and what's been working elsewhere, how we can improve work here on a local level. Again, I want to commend you on your efforts and everything you do, and thank you.
Thank you, Manager Musaitif. And Manager Valadez?
Yes, I just had a question. On the targeted populations, I did not see anything about uninsured. Can you go back to that slide, please?
For which part? Is it on the paid media or is it on map member, the
It was
outreach?
one of the first targeted populations
Yes.
in your
I know
presentation.
it's the very
Yeah.
first outreach slide.
Yes, Manager Valadez, I'm sorry, I should have been more explicit, but I do mean to imply that, yes, the uninsured Travis County residents whose income are at 200% FPL and below.
I'm looking for that slide.
I think is it this one?
It's number
This one?
11.
That one right there, your
Correct.
priority populations, I did not see there. If you can go back, please. Go back, right there.
Correct.
Yeah.
We should have something that says uninsured population there,
Yeah.
because I don't know who is inferring that uninsured is unhoused, or hell, there are more people with Social Security that are unhoused than people that don't speak the English language, that have no access to no services or insurance. So I want to make sure we make sure that our population knows that we're talking about uninsured, because that's what we were required to do in our 281 mandate. And then going back to where you are talking about where the areas that you are reaching out in community engagement, if you can do that also. That needs to have uninsured somewhere.
Correct. So, Manager
Or
Valadez.
maybe where you have unhoused individuals,
It's,
unhoused and uninsured. No, that's separate, because it's separate. People will confuse it. They'll think You have to be unhoused and uninsured in order to be get covered. No, it should be a separate square.
Thank you, Manager Valadez. The MAP eligible families in areas than lower than expected enrollment would be specifically speaking to those under or at 200% or below. But I can definitely,
Then I
be
guess
more
it needs to be a better language, because one of the things that I don't see that we're doing is saying that, that our targeted population is under 200% FPL. I don't think I saw that.
Yeah, actually, that is always our target audience, low income.
No, I understand that, but if we're educating people and we don't have it in black and white,
Yeah,
in print,
And it
I
does
think that
sometimes.
we're missing a step, okay? I assume people those that we have yet to communicate with and get on our rolls, those are the people we need to reach out to. Going out to, again, the community engagement, I noticed that you had a lot of stuff in Runberg in the north, but I didn't see anything in Dove Springs, Del Valley, Eastern Crescent, or Montopolis. And I'd like to know if we can, what the status is on reaching out into those particular communities.
yes, and we do attend meetings
If
there
you
as
can, no,
well.
if you can go to that on the screen, please, I'd appreciate it.
It's probably number 16, 17?
You see here where you have educate? Go back one more, hon.
one more slide.
One more slide, please. Thank you.
And these are, just as a reminder, these
No,
are
one
only
more.
for
Go
the
back one more.
first quarter or so of this fiscal year. And again, this is not, this list was not completely exhaustive. And we are, currently working with the Dove Springs Community Alliance and attending meetings with them, as well as others.
And just a final note, all of our outreach, engagement activities, and paid advertising and paid social media is driven by working with our data and strategy team to look at the high need areas. So either areas that have high numbers of people who are low income unenrolled, or high enrollment in MAP, but underutilized. So that's what drives all of the work that we do. We can provide you with a list of zip codes. The list of zip codes is relatively consistent, but it does change from time to time. So demographic report, strategy data team, and then helps drive all of our communications, outreach, and engagement efforts.
And if I can speak to this slide real quick. So the Community Health Champions program has been, we are scaling that program, and it is intended to be a very deep program that requires a lot of staff and other resources. So we are scaling that program, whereas last year we only had it in Rumberg. This year we're adding Colony Park, one in English and one in Spanish. And we are exploring scaling it to other areas, but that doesn't mean that we're not in those communities. We are in those communities. In fact, our existing alumni network is fully embedded in those communities, and we are in ongoing conversations about sharing the information that we need to share with these communities through them. And so these are very deep programs, and we are scaling that program more and more every year.
Okay, and also there was a question about the, you were talking in terms of percentages of people who are accessing Facebook, social media. Can you hit that slide real quick, please?
I don't have a number. Maybe that was your slide. 5 or 6.
You had Facebook,
I think it's the first slide under social.
maybe that was it back there. No, well, so people who use the social, US adults, what is the Travis County adults?
Oh, okay.
That's the website.
I could care less about US adults when I'm talking about branding and targeting Travis County. That's the information I want to see.
I think this is what you're talking about.
Yeah, thank you. This is what I was looking at. And I wanted to know what this data, that's based on, who is DECA? Digital Empowerment Community, who is that? Are they Spanish speakers?
It's a local nonprofit established by the city of Austin that incorporates numerous community organizations and other partners. I attend the meetings, so I don't have an exhaustive list, but yes, it does.
I'm looking for targeting out, reaching out into the non-English speaking population. And I don't know how good a job they do, but I think maybe this is going to be a good time for me to suggest that we will go back to making contact and reincorporating or reaching out to Jill Ramirez and Isabel. It's now called Promo Salud since Jill got a clean bill, and I think it's time to reach out to them because I consider them my Spanish-speaking experts.
Manager Valdez, we've been meeting with DECA for a couple of years now, and we have been assisting them with their Latino outreach as well.
I appreciate that, Yvonne. I think that's you. But I hadn't seen DECA in a presentation yet. I think this is the first time I'm seeing it. That's why I'm asking.
How about we provide more information on DECA? Would that be helpful?
But that doesn't minimize my suggestion that we go back to reaching out to Jill and Isabel, who I consider our experts, and they're the ones that dragged Central Health kicking and screaming into the community health promotora salud world. So aside from this, thank you very much. I just want to see better data based on actuals for the non-English speaking population, and that doesn't only include Spanish. Thank you.
Thank you. And Manager Jones? Yes.
I just have sort of three quick questions. Follow up on what Manager Valdez just asked. On the internet access, excuse me, what about the over 65?
That's right.
Do we have information with regards to that?
I don't know if we get that granular with the data. We might have to do independent research. This is just what's provided through the census and through Nielsen, but we might be able to reach out to someone.
Well, we can definitely get it regarding social media, but I think you're looking at the internet slide. Am I correct?
Well, I was really talking about social
Okay.
media.
We can definitely get that. So Nielsen, the demographics break down socioeconomic, age, gender identity. So happy to provide that with
Okay,
to you.
that would be very helpful. The second question relates to this slide here. I was wondering, and this is more of a marketing or question, is it possible that we could insert in the bottom of these our new logo so people can get the connection?
Yes, so these are from the previous campaign, and so that is part of the whole implementation plan. So by the time we get around to ACA next year, it will all be rebranded with the new logo. That's just an example of what we were running October to January.
Okay, my last question actually goes to the logo here. I know we've had extensive discussions on this. My question goes to, and forgive me, I think you've done a fantastic job with this. You're to be commended, you really are. But someone who comes from outside and still sees this, yes, visually they'll see the connectivity there. But actually, in terms of an enterprise, or the question is, if someone just sees this here, community care, with the logo, and is not familiar with Central Health as the other, it will take some time for them to get acclimated to that. I don't know if I think I raised this question when we had the discussion. Is it possible at all in each of these, our two other enterprise agencies, to insert something to the effect of an enterprise of Central Health, or something to let someone visually and see that there?
Thank you for the question. And so there is going to be first of all, a logo lockup. There'll be times we want to show all of the affiliate names with that one logo. The logo is just the visual stamp. Now comes the whole brand story. So anytime you see us talk, write, show anything about the system, the Central Health system, we're going to make that connection, whether it's website, paid media, social media, media relations, speaking with the Travis County commissioners during budget season. So there is going to be a logo lockup that shows the brand, the mark, with all of the affiliate names.
Okay, so
and we can we'll be happy to. We are now in the process of building out a full, what we call a style guide, but it's going to have all those iterations that you're talking about, plus the messaging that goes with it, so that when community care is talking about the system, we're talking about the system, Sendero, it's always hopefully going to be exactly the same.
And in addition to that, the goal is to build enough brand equity of the icon itself, so that the icon itself is representative of all system partners, and then that'll be a standalone mark, just like we see with other brands that are very well recognized.
That's where I was going, is that at some point we should be at the point that
Right.
we don't have to spell it out.
Yep.
The logo will speak to
Right.
it.
And just to be realistic, if you think about brand marks like the Apple icon, the Apple icon, that's not my phone, or the Nike logo, those marks, they don't happen overnight. They're built through, in those cases, billions of dollars in or maybe hundreds of millions, no, probably billions, in marketing and advertising. But also, it's not, you don't just pay to build your brand and to create the story. It's through authentic, trustworthy messaging and delivering on the promise. So what is our brand promise? If it's connecting low-income Travis County residents to care and coverage, we have to deliver on that and begin to build that brand story for the system, not just for each separate entity. And we'll be happy to talk more about that in even greater detail in another meeting, or with you offline.
All right. Thank you.
Thank you so much. Yes, and Manager Kitchen?
I have 3 questions. First off, just thank you very much and congratulations on the branding. I know it's taken a while and it's just really amazing, so we really, really appreciate that. So my first question is, and I think you alluded to this, Ted, I think you said something about in March, talking about the board in the community or something like that. I wanted to ask you what you meant there.
Regarding the brand,
No, this was not brand. I'm sorry, I was like segmenting. We were talking about community engagement.
well, 2 things. I think, I may not be following. We're coming back to the end of March for an update at the executive committee regarding how we promote and raise awareness about board meetings to hopefully
Okay,
drive
that's what it was.
That's going to be on the
Yeah.
agenda at the March executive
Okay,
meeting.
so I wanted to make a comment or an ask on that. As part of your thinking about this, this is just an idea that I think I had talked to Manager Jones about, and that is to consider ways in which we might get the board out into the community. So maybe either through community conversations participation or listen. Okay, so that's already on your radar screen. Okay, good.
Absolutely. We will always want to have you at every possible event, and I know some of you make it more often based on schedules, but absolutely, you are probably our greatest brand ambassador, so we need you there. And also, we're going to talk about how you can help spread among your own networks, whether it's social media. Some of you are more active on social than others, Manager Misaitif, and it's a great benefit for the organization because she helps spread the word about Central Health, but also in person. And so, yes, that would be part of the conversation.
Yeah, and what I'm thinking of is, and y'all can give some thought to this and we can talk about it in March, but I'm also thinking in terms of board meetings in settings other than here. So whether that is a formal board meeting or a listening session between the public and the board. I'm not talking about the board coming to community events, which is very important, and I appreciate that. But I'm just asking you guys to think about it. We could talk about it in March. It could be helpful. So
We have been thinking about that. We've actually had a conversation with Manager.
I know this is his
Jones.
idea. So
And then I think we want to also just kind of reintroduce our community conversations in terms of how we use those for community engagement, and then
Okay.
the role that you can play there as well.
Okay, second question. This is about the community health champions, which I just love the idea. I think it's a great thing. Tell me how you keep the alumni engaged. I know that being in groups like this, people can kind of lose their connection over time. So what's y'all's strategy there?
I can speak to it real quick. So it's shifted over time, especially
Okay.
during the pandemic. We lost a lot of engaged individuals through the pandemic, but we have been working really diligently at re-engaging them. So the main, there's several mechanisms where we keep them engaged. One is a very thoughtful and intentional email that goes out to everyone. We also use WhatsApp for people who are more familiar with WhatsApp than emails. And our baseline languages are English and Spanish, and we're having conversations about other languages, but that's one. Another way, and then we also have a committee. We have an alumni engagement committee.
Okay.
That with the highest or the most highly engaged individuals. It's about 10 to 15 people, it varies, and they are the ones who help us come up with strategies to ensure that we're engaging with them throughout the year. They meet once a month, and they just held a retreat, a planning retreat, which was a 4-hour session a couple Fridays ago, where they really thought through what it meant to have everybody elicit more engagement, not just in the form of advocacy, because they really want people to be engaged through advocacy, but also in the form of volunteerism. And so we're working through all of that.
Okay.
And it was the alumni committee that helped come up with the idea for the accelerated program, correct?
That's right. So,
Okay.
and many other ideas that they help us come up with. The meetings in a box idea of taking meetings on the road, and they're helping us design those things. So, for example, we tested that last year, and sometimes it just didn't work, that the format that we had it in, and so they're helping us redesign the concept of meetings in a box so that is more engaging when they take it on the road with them.
Okay. So my last question is just, I think I know the answer to this, but just wanted to double check. My last question is about the website. So our website has all the board and committee meetings on it?
Yep.
And it has it for the whole year so people can plan if they wanted to?
We updated the archive, and I think it extends back to the beginning of the COVID pandemic.
Okay.
And prior to that, we have a form that says if someone needs a recording or minutes or an agenda or whatever, they can request that specifically. But we do have video recordings and packets through 2021.
And we've rearranged. Mike showed it may have happened quickly, but the homepage of our website, one click gets you to the Board of Managers and meetings page, and then the meeting schedule is almost at the top. First, there's some obligatory language about the Board of Managers.
Yeah.
So it's as close as we can get to making it take over the homepage.
Okay, and then the schedule itself is for the rest of the year, so people can see if they want to, okay.
I believe
Thank
we have
you.
it updated through the fiscal year,
Yeah.
and then we'll
Okay.
be updating it as Brianna sends us updates.
Okay, that's great. Thank y'all very much. This is very helpful. I really appreciate what y'all are doing.
And Manager Musaitif.
Two things. In terms of the meetings, I know pre-pandemic, they used to be televised in some.
That's right.
So there's a way that we can revert back to that. I think it's accessible. You don't have to answer
Well,
now.
no, but we're going to also talk about that at the
Okay.
March meeting, so I don't want you to think we were. And there's also a memo, was it already in the packet? There's a board.
So I'm just communicating
Yep.
what I've heard. The second part, as a fellow alumni of the Health Champions, yes, and I met as well as one of them. I think also what you've been doing in the past, and also you sending out calls for volunteers, and that's another way that they've been engaged as well. So they're volunteering at certain events. So I think you've missed that point.
Yeah, and Yesenia Ramos is in the audience. She and Christian Nelson are health manager, our Health Champions program. We always have health champions at every single event that we have. So the folks that are setting up tables and hauling water and tearing down the event, oftentimes our staff and our health champions.
And Manager, yeah. Yes, go ahead.
I just want to thank Maram for bringing that up again. But I have been on that kick since we were kicked off of the Travis County website. And I know y'all have told us that it was because of technology. But then I remember we went through that upgrade. We went to AISD, we came back, and we ended up somehow or another on YouTube, which not everybody can access. So going back to the Travis County channel may be a necessary step. It's not an evil step. It's a free channel, and it's paid for with our public tax dollars. So that would be, if at the very least, that would be something that we should do. So I commend you all for having us there originally, because I pushed very hard for that when the rest of the board was a little hesitant, or staff necessarily was hesitant. But I think we need to go back to that. Thank you, and thank you, Moran, for bringing that up.
Yep, no hesitancy. There's a memo that details that,
No
and we look
hesitancy
forward
now.
to talking to you more at the March 27th meeting about that, and answering questions and having a robust discussion.
Thank you.
And thank you all so much. That was wonderful. Oh, I'm sorry. Yes, yes.
Just want to add my appreciation, congratulations to the team. I also want to just take a moment to acknowledge the partnership and leadership of the CUC team in particular. I know this was not an easy step. There was a understandable deep connection to a 15-year brand equity that had been built there. There's a sense of loss paired with a sense of hope, I think, of where the future could go. And I just want to acknowledge the leadership and the trust that we're going to build upon and do together. So just want to say that and extreme appreciation.
Thank you all so much.
Thank you for your time and questions.
I have a quick question. Hey, Ted, what is our colors called? Do you know the names of those colors? If you don't, it's okay. I just thought you might. I really appreciate it.
Well, now it's called Central Health Dark Green and Central Health Mint Green. I'm kidding. It's dark green and mint green, and we actually have the CMS colors that we'll share with you. It's part of our brand guidelines. But don't be fooled by what you saw on the screen.
Yeah, I know. It's always different.
And it's beautiful. So I can show you on my Apple computer.
Okay, thank you.
Thank you.
Okay, no motion is necessary. So we're going to move on to item number 2. I'm sorry, item number 3. Receive an update on Central Health's behavioral health and substance use services, including information on direct and contracted services, diversion and deflection pilot services, and potential opioid settlement funding. John Morgan, Dr. Alan Shawsa, Monica Crowley, Katie Coburn, Cynthia Galegas, Dr. John Weems, Dr. Nick Yagoda, and Dawn Handley will be presenting.
We will not all try to sit up here at the same time, but we'll try to do this as efficiently as possible. Good afternoon, Dr. Brenson, managers, thank you for your time. We are really pleased to bring you a pretty thorough overview, both at a high level and a couple of deep dives into Central Health's work in collaboration with partners to develop a comprehensive system of care for our patients that includes and really emphasizes access to behavioral and mental health care as well as substance use treatment. So that'll be the focus of this portion of our presentation. We're going to cover quite a bit of materials. Cynthia Gallegos, our VP of Operations, is going to cover our contracted network, just to give you all a sense of the scope of services and the magnitude of those services that we arrange for today for our MAP and MAP Basic members. And we've asked our partners at Community Care and Integral Care to come speak to current services in place, new initiatives for this year and progress to date, and also opportunities for us to continue our work going forward. And then we'll speak briefly to some of the changes for opioid settlement funding that will be coming to Central Health in the near future, as well as a quick update on our direct practice development and the substance use and behavioral health aspects of our practice here at Central Health as well. There is no action being requested today, but this is certainly informative of future deliberations for the board as we enter into budget season. Next slide, please. So as a reminder, mental health and behavioral health are key components of our delivery system and a specifically named area in our community health needs assessment and in our service delivery strategic plan. While mental health and behavioral health and substance use are called out in some specific cogs on this diagram that we try to ground ourselves in, it's also represented in that dotted line of each of the main cogs that you see on the slide. And as we think about mental health, behavioral health, substance use treatment, during the discussion today, We really have to think about it across our system and how it connects between different components of our system. So just want to raise that for the board's consideration as we move forward. And I will turn it over to Cynthia.
Good afternoon. Good afternoon, managers. So I'll go ahead and kick us off with mental health services, starting with Integral Care, one of our longstanding partners. Integral Care has seen an average of just over 26 encounters on an annual basis. This includes encounters across their inpatient psychiatric services, crisis respite, and intensive outpatient services areas. Based on direction from the board at the beginning of the fiscal year, we've added an additional scope of services totaling $7 million to support outpatient clinical services provided by Integral Care. And just last month, we expanded this partnership to include psychiatric emergency services, psychiatric emergency services, both of which you will hear more about later in this presentation. I'll move forward to community care, Lone Star, and People's Community Clinic, our FQHC partners. Each of our FQHC partners have worked towards offering mental health services in various capacities. You'll see here services outlined include behavioral health therapy and counseling services, psychiatry services, and expert services. And just to pause, ESPERT, for those of y'all that may not be aware, means screening, brief intervention, and referral to treatment. These are offered across multiple settings. And just for reference, we project that community care is on track for just under 16,000 encounters for this fiscal year. Lone Star, a little under 2,800 encounters projected, and People's 1,200 projected, or just under.
A quick question. When
Please.
you mentioned integral care before, you said 26. I assume you mean 26.
26,000, sorry.
Okay, thanks.
I appreciate that.
I thought it was. I just thought
let's see, yeah, yes, I did, apologies. 2,600, I apologize. All right, so I'll move us forward to SIMS. Lastly, big difference. Our partners at SIMS also offer mental health services that you'll see outlined here, which include substance use disorder services, psychiatric services, and behavioral health services for Austin musicians. And just in FY23, there were just over 400 encounters that were offered.
And just to clarify quickly, Manager Kitchen, to your question, I think that the 2,600 is related to the historical portion of our services agreement that covers the higher acuity services of intensive outpatient. These are the actual psychiatric admissions into the psychiatric hospital facilities, and the extended observation unit at the Herman Center. There are tens of thousands of encounters that are anticipated as part of that expansion that Cynthia spoke to at the beginning of this year that covers the outpatient clinical services provided by Integral Care in their facilities. That's psychiatric services, mental health counseling, case management, all of those services that we added as of October. And then there's the third component, which is the psychiatric emergency services that we just put in place recently, earlier this calendar year.
Thank you for that clarification. All right, we'll move to the next slide for substance use treatment services. So familiar faces here with our partners. We've got a couple of additional or new partners that we'll speak to. At a glance, community care MAT services are now several years old and are offered through a hub and spoke model, covering several locations and serving just under 2,000 encounters annually. We'll be speaking a little bit more on that today. And then Integral Care MAT team is a new access point established just last year, serving patients with a dual diagnosis of opioid use disorder and serious mental illness. Community Medical Services, also known as CMS, is a relatively new partner. We contracted with them back in the summer of 2022 to expand access to methadone therapy and Suboxone treatment available to our patients in the community. In FY22, just as a partial year, they saw a little over 33 unique patients and expanded to 92 unique patients in FY23. addiction and psychotherapy services, known as Dr. Oshbach internally. Offers the same services as outlined on CMS. We partnered with this provider at the beginning of FY23, and she was able to see 45 unique patients that year. And then Sobering Center, this is one of our newest partners as of January of this year. In addition to the sobering services that they provide, Central Health contracted with Sobering Center to begin offering a safe holdover opportunity for patients who are interested in substance use treatment until a patient can be connected with outpatient treatment services or an inpatient treatment facility. In about 2 months, we're currently tracking that they are to have seen or held over just under 30 individuals for connection to treatment. And then last but not least, I'll kind of speak to the other category listed on the slide. This year, we were able to begin offering naloxone without a prescription and without a copay, and we are exploring options to make naloxone even more readily available in partnerships with CUC. We are also working with the City of Austin to transition our historical funding to support medical services that they provide, including opioid treatment inductions and transitions to ongoing treatment. And with that, I think we get to transition to
Just
John.
before we turn it over to Dr. Shalsha, I just try to provide a little more context. That this has been a very active area for us, a very active build over the past few years, and an area of emphasis. I don't think there's a single area that Cynthia outlined that we don't still have work to do. But I will say with the support of our partners at Integral Care and Community Care and the others that Cynthia has outlined, our community health needs assessment identified this as an area with moderate gaps and not severe gaps, not significant gaps like several other areas in our system. So we're extremely grateful for the partnership that we have with the individuals you're going to hear from here shortly.
Good afternoon, Chair Brinson and managers. Alan Shelshire, Chief Medical Officer for Central Health. There sits significant opportunity in the mental health space and as related to addiction disorder and the build out that still needs to occur. A couple days ago, though, we were sitting together as a team, Central Health, Integral Care, and Community Care, and just talking about what some of the theoretical next steps may be, and it gave me kind of a chance to reflect. And I think, Cynthia and John spoke to the fact that this work has been ongoing for about 6.5 to 7 years. And I think we always look and point out, I think, the times we stumble and fall and areas that we sometimes don't succeed. And sometimes it really benefits us to take a look back and just celebrate the victories and the partnerships that exist. It was about 6 or so years ago, I think 2018, when I remember sitting in a room with John, with Dawn, and with Nick. John was representing Central Health and advocating for the build of addiction disorder infrastructure, focusing on the contractual arrangements and the financing. And Dawn was doing a similar, focusing on similar areas within Integral Care. At that point, I'd recently joined Community Care as their Chief Medical Officer, and Nick was this celebrated leader within Community Care. And it was actually Nick that, when we first sat together and talked about the rollout of Suboxone, it was Nick who developed the processes, the protocols, many of which still exist today. It was about 6 years ago. And over the subsequent 6 years, so the programs jointly have increased in scope and in sophistication. And so the partnerships are strong. Obviously, there are opportunities, and I think as we sat together, we're all pretty excited because we're in a new space. And this is a prime time to build those bridges and really start building out. It's at this time that I'd like to introduce Nick Yagoda, Chief Medical Officer for Community Care, and John Weems, Associate Director of Addiction Medicine for CUC. And I'll hand it off to them.
Good afternoon, managers. Good to see you again. Thank you, Alan, for the introduction, and to emphasize this, when we did begin this project, this larger initiative, it was something that was very interdisciplinary and involved a ton of input on all sides. A great deal of thanks to those from Integral Care who were there, who are here now, as well as those who were previously part of the team who have since moved on to other endeavors. So we are very grateful to have all three of us here being able to represent the work. I'll start off briefly with a couple of introductions around how we think about substance use and mental health to some degree from a population health lens. We have about 7 slides to get through, and hopefully we can keep it as tight as possible. And then we'll be around at the end of everyone's presentation to answer any sort of questions. So if we go to the next slide. We will always call out naloxone every opportunity we can. We can go to the next slide. Population health model. So this is a model that I'm not sure everyone in the room has been familiar with. It's one that's emerged out of, and Dr. Brinson, perhaps you're familiar with it, it emerged out of the HIV landscape, one that understands different operational steps and different populations that need specific and unique outreaches in order to comprehensively address chronic disease. So on the leftmost side, we see primary prevention. This is the general population that's represented. And this is out of a study that tried to apply the HIV learnings to opioid use disorders in particular. That next column is secondary prevention. These are people who are using drugs who are at risk for disorders but do not have a diagnosis. And then as we get into the next bucket, we're going to really talk about those who have a diagnosis of a chronic disease and ones that we are targeting in much of the efforts of these specific clinics, which are on the treatment side. It is probably reserved for another conversation how we start working on the prevention side. So that first column is represented the total number of the total population. I think this was published in 2018. The total population in the United States with an opioid use disorder. And in subsequent bars, you'll see the red. That is the gap of individuals that we might ideally be able to reach if we had a 95% threshold of engagement at every step of this cascade or continuum of care. The blue line represents in reality where we were living in 2018. It is those red bars that we design programs to outreach and capture and bring into safe services. So first is diagnosing the individuals. Next is engaging them in care. Next, we initiate medicines for opioid use disorder. Again, this could be applied in a different frame of reference for other chronic diseases. In this one, we're talking about opioid use. Next, we have those retained in care for 6 months, as we'll talk about later on in this slide. Retention is not a straightforward process. It's often quite complicated. Then finally, we get to the last bar, which is those in remission. You will see there is a scant blue line on that bar. That represents some of our greatest challenges. Those are where we stand to introduce the greatest counterbalance to the epidemic of deaths that we've been seeing in the opioid use disorder. If we were to identify 4 key priority touch points along this continuum of care from diagnosis all the way to remission, it is at the point of where people are identified as having overdosed. It is those who have injection wounds. It is those who are justice involved and those who are going through detox. So as Alan outlined and then Cynthia outlined, as we look at this landscape and it sometimes feels too difficult to boil the ocean, we should not. We should focus in on those highest yield points. We would recommend that these 4 touch points are probably the highest yield. And again, as I mentioned before, recovery is a long process and it is not straightforward. What we expect and what this graph may indicate is a relatively step-by-step, knife-clean process. Is not at all the case. And often people have to be reintroduced at various stages of the continuum. I'm going to hand it over now to Dr. Weems, who will give a bit of a vignette and be able to walk through the next couple of slides.
Thanks for having us. We love this image here of what recovery looks like in movies with the expectations versus the path we get to walk with our patients. Our clinic is at Southeast Health and Wellness Center over by the playground, if folks know where that is. And as I was walking by today, I was reminded of a story that kind of highlights this. I have a patient who I only see on the playground because his life has become about a family member of his. I'll change some details up, who's about a year younger than my kiddo. So all of our visits are there. But when we first met him, he could barely make it in the clinic. He couldn't walk because he had one of his organs doesn't work anymore because of a direct result of the drugs he was using. Most addiction treatment programs have an abstinence requirement, and so this person would not have been acceptable to those programs. And I think a difference with the programs you're going to hear about today that we'll talk about is we meet people where they're at, and they show up with organs that don't work and issues with drugs and behavioral issues and a lot of social determinant challenges. So over the first couple months we met him, we were really just managing that organ that wasn't his medical issues, and all the while building trust to try to convince him that we were going to be with him till the wheels fell off. And the wheels fell off intermittently. They were hospitalized. The central health teams, transitions of care teams, respite teams were a big part of his success. And particularly the respite program, I think, is probably why he was able to survive many of these challenges. Mental health is another major thing that this individual struggles with, and being able to connect with integral care and have a longitudinal relationship there has also been life-changing. And now all of our meetings are at the playground talking about like which car seats our kids can fit in and what's going to come next because he's stably housed, doing well. And I think highlights a couple things. There's drugs in his life at the beginning, and they thankfully have left and things are going well, but it can be a long road. And then addressing both the physical health concerns, mental health concerns, and the substance use issues in a one-stop shop in partnership with other organizations was a big part of his success as well. So the rest of the presentation is for him and for all the people we get to walk along with, building trust and serving the community. So go to the next slide. So this is our clinical model here. So the two figures, I'll start with the one on your left, is kind of how we conceptualize what we do at the CUC Addiction Medicine Clinic. It's a medical care team in partnership with our case managers, counselors, and peer coaches. It's a very strong team, and the visual there is sort of our vibe. It's like a dance circle, and our patients are in the middle, and we're encouraging them. That's our approach. It's defined by team, building trust and relationships with our patients. Relationships with external partners are another big part of our identity, like the story Alan told about the beginning of the clinic. And so I'll start about 10, 11 o'clock there on the wheel of partners. So one is Austin Travis County EMS and Mike Sasser and his bridge team, starting folks on medications for opioid use disorder after overdose in the community, as a key partner of ours. I got to hang out with Mike the day before his first dose that he gave out, and then he was in the Statesman this weekend after having served their 500th patients. And the bridge where that program leads is to us, to integral care and community care. So a key partnership. Another is with our partners in corrections, and we're looking forward to diversion. Dr. Maher is a close partner. We collaborate to take care of patients on a weekly basis. Community agencies are key because especially our patients are facing so many social determinants, and that spans the range from housing to harm reduction. And our street team is over at THRA on a regular basis. Another is hospitals and emergency rooms, and particularly Del Seaton Medical Center and the B team has become a national model about how to address this key gap between hospitalization and longitudinal care for opioid use disorder. That's an ongoing partnership, and we'll talk about some of the results we've published along with those partners. And then CUC referrals. So we view part of our work as just being where folks can go after they hit any door of community care. And if they're struggling with a drug issue, including alcohol, we're there to help. So there's no wrong door to treatment in our health system. And then external treatment partners, in particularly the opioid treatment programs, which y'all heard about earlier in town, and programs across integral care. And then finally, community and walk-in. So when folks come to our clinic, we can help them or their family members the same day get connected to care. And that's the definition of part of the definition of a low barrier, low threshold clinic. So that's our model. Low barrier, high support, guided by lived experience, which has been a key part of our leadership team and our clinical team from the beginning. evidence-based practices, comprehensive primary care, so you can deal with the medical issues that result from drug use, keep people engaged, healthy, alive. We go to where people are at. So we're really work very closely with other community care teams that are out on the street and helping our folks experiencing homelessness. This is all possible through our collaborations with Central Health and community partners. Next slide. So when we think about quality in addiction treatment, particularly the treatment of opioid use disorder, retention is the key metric because it's such an important proxy. When people are on medications and they're engaged in treatment, they're far more likely to be alive and thriving, and so it's a proxy, and it's our key metric. What you see here was our fiscal year 2023 retention numbers. So as you go left to right, at 14 days we retained 86% of patients, 76% at 30 days, and then 50% at 6 months. So that's a big drop off, right? And frankly, an unacceptable one that we need to keep improving, and it exceeds the national benchmark by a good amount. Why? A couple things. One is addressing barriers to care, particularly transportation. And telemedicine has probably been the most important innovation in addiction medicine in the last 5 years. And we utilize telehealth to keep our patients engaged. We've expanded services significantly, and soon that's going to include like evening hours at our clinic there at Southeast Health and Wellness. We now have a psychiatrist who's seeing patients with us in the clinic. And through this period of growth, we've maintained a culture of engagement, of hospitality, of welcome. Thinking back to the playground outside of Southeast, most of my visits with that individual were during times things weren't going well. And we tell people all the time, we want to see you on your roughest day or your best day. And we hope that culture addresses this stigma that so often accompanies drug use and keeps people out of care. So you go to the next slide. And so what you'll see on your left is another bar graph headed the other direction, which is new starts for buprenorphine. So that's the medication we use to treat opioid use disorder. And so significant year-over-year growth. And most recently, from 2022 to 2023, our growth is not just in treating folks with opioid issues, but also issues with alcohol, stimulants like methamphetamine and cocaine, and sedatives like benzodiazepines. So we continue to grow to meet the patient need, which is about more than opioids, because different drugs affect our communities, and we've built the clinical model to address those as well. The other thing you'll see there is a heat map of Travis County zip codes, which we did last year, I believe. And what it shows, the darker the color, the Central Health turquoise, and I think that's what. Yeah, the darker Central Health turquoise is what the zip code our patients reported when they come to clinic. And again, we're there in Montopolis. And what this told us is, the northern parts of Travis County are an area where we're very interested in expanding services to clinics like ours. Go to the next slide. And so this is a slide that sort of speaks to how what are we expanding towards? And so what we did here is we took the National Survey on Drug Use and Health, which is the best, but fairly limited, but the best estimate we have of the burden of illness related to substance use disorders in the United States. It's an underestimate, but what you see there is the percentage of the population with severe, and then heading down to mild to moderate, and then no substance use disorder diagnosis. SUD is substance use disorder. And then we applied those percentages to the projected Central Health patients in 2024. And that's what's on the pyramid. So we project that there's more than 6,000 folks who with a severe substance use disorder, which will need a fairly intensive set of services to help. And then a much larger section of folks with mild to moderate substance use disorders. And then a very large population of folks who don't have substance use disorders, but interventions that have been shown to prevent substance use disorders or complications, drug poisonings in particular with unanticipated fentanyls. You'll see there, and I can't see well enough to read those off, but I think they include primary care, behavioral health, trauma-informed care, but also social determinants investments, which are critical. Oh, these are good ones to have not forgotten. Community substance use disorder education, because again, the stigma of substance use and disordered substance use keeps people out of care. And then harm reduction interventions like naloxone. Traveling back upwards for folks with mild to moderate use disorders, primary care based addiction medicine, about which Pat has a question because he's put a question mark next to it, is another one, supported by substance use disorder e-consult. So what that is that any provider in community care can place an e-consult and get expert recommendations about how to treat the patient in front of them, no matter where they're being seen in Travis County. And then for folks with other issues, they can be seen at our clinic for sure. And then finally, going all the way back up to the top of the pyramid, for those with severe substance use disorders, being seen at our clinic, at Integral Care, and across the methadone clinics are the interventions that would help this community the most.
I want to emphasize that our model is very much about taking advantage of the window of opportunity we have with the individuals we are fortunate to care for, and we try and wrap them around with every possible service they could need in the moment of care. That requires a adaptive and versatile team, one that I think some of the earlier slides spoke to. And so that is a team that requires a lot of investment, and we're grateful for Central Health's vision on seeing along with Integral Care's structure as well, and seeing how multidisciplinary these types of efforts need to be. The next set of slides, we know that today was to talk about substance use and mental health, mental illness. So we tried to whip together really quickly how we're applying a similar lens on the mental health landscape. We are limiting our conversation today to just one slide about mental health, but we'd be happy to speak further as needed. Again, we did a rough projection of Central Health patients based on the 4% growth you saw year over year last year. And so don't hold us to that number in particular, but we're just trying to really show scale. And that despite best efforts and great improvement in the last couple of years, that we have a substantial load ahead of us to be able to undertake. Also, what is inadequately represented here is the scope of work that our partners like Integral Care and others are doing. It is by no intent to represent that you all focus on serious mental illness or serious substance use either, but for the sake of space. We just wanted to give a nod to some of the other leaders in this space. On the mental health space, we do have intensive care for those with serious mental illness who have substantial medical needs that draws them sort of magnetically to community care to ensure to take care of those physical health issues. First and foremost, we need to make sure, again, within that window of opportunity, that we're trying to address all their needs at the same time. We've built out a psychiatry practice over the last couple of years for those middle to moderate patients that represents, again, a very substantial bunch. We have the ongoing primary care behavioral health model in psychiatry, and have in the works a number of additional models to supplement and layer over that for different levels of complexity. And then lastly, reflecting a lot of what we saw in the substance use project, we have a number of different program and models to build on. We won't belabor all the little details, but suffice to say we want to convey how we are thinking at a population health level. And the next slide sort of wraps it up in summary, thinking in the 4 buckets of what is often thought about from a health equity perspective. What is needed to drive this is 4 buckets of system, space, staff, and stuff. So on the systems level, navigation is key to this. We have a number of really invested partners getting through this safety net system. Is not always straightforward for our patients. We do so by creating a no wrong door approach. We do substantial outreach, wraparound services, and warm handoffs. We need payer level data to understand where our gaps are, where our needs are. And so integrating data sources from all of our partners so that we can create really intentional and strategic approaches to these populations is going to be key. And most importantly, perhaps, is that we build with and build for the community. Their voice needs to be leading all efforts on system design. And over the last couple of years, we've seen some substantial investment of the communities in hearing the community's voice and letting them be the guiding light. On the space side, we just need more clinics. We talked about the Northern Clinic. We need more mental health clinic access and higher level of addiction care. In particular, John mentioned the inpatient residential intensive outpatient care services. The growth we've seen in the last couple of years has been excellent. On the staff side, more peer support, more providers, both of which we're either contracting with or recruiting for right now, but also building a workforce pipeline in education so that the community we serve can also be those who are delivering the services. The extent to which we can bring in those with lived experience to serve on our teams builds trust more than anything that we can do otherwise. Lastly, staff housing, the ongoing PSH work of which we're part of a large consortium is going to be critical, particularly for those most vulnerable, experiencing housing complexities, saturating the community with naloxone, and then probably reserved for another time are some of the leading best interventions for stimulant use disorders, which is contingency management. It is not worth getting into the details today, but we do want to highlight a couple of terms that when there's larger discussion about how to invest, this is one of them. And then for particularly around transitions for people with opioid use disorder, there are more diverse medications out there that can help bridge periods that don't depend on a daily pill, but long-acting injectables are another important aspect of the armamentarium we hope to bring. So that's a lot, but we wanted to highlight, one, the work that's going on, and two, how we see the next couple of years identifying the gaps that we can fill collaboratively. Thanks very much.
Thank you very much. And any questions, or shall we wait?
If you don't mind waiting, if we could get through the rest of the materials,
Yes.
just to make sure we don't run out of time, that
Gotcha.
would be excellent. And thank you, gentlemen. Really appreciate you both taking the time to be here and away from community care in your practice. And again, there's no ask associated with today, no approvals needed, but as you can see from the
Thank you. We have quorum, so we are back. Manager Musaitev. Manager Musaitev. We're back in session.
All right, so just briefly, again, want to thank our partners at Community Care for spending some time with us. There's no action being requested today, but wanted you to have a good sense of the work that's currently ongoing, and that some of these initiatives that are on this last slide here are still yet to be addressed even this fiscal year. Others, I think, we'll have more discussion on as we enter into our budget deliberations for FY25. But I'd now like to just briefly introduce our partners from Integral Care. Dawn, to my right, is the Chief Operating Officer for Integral Care and has put up with me, partnered with me for many, many years, ranging back to time here at Central Health and at Community Care and when I was at Lone Star Circle of Care. So always grateful for her partnership in all of these endeavors. And then both Marlene and Marissa are licensed professional counselors. And so that I don't get this wrong, Marissa is the Director of Crisis Services and Justice Initiatives for Integral Care, and Marlene is the Director of Systems of Care. And I'm super excited for them to provide you all an update on services that are ongoing, as well as some of the efforts that we've worked on here jointly over the past 6 months since the budget was passed back in September. Turn it over to you all.
Got it, thanks. Good afternoon, Dawn Hanley. I'm the Chief Operations Officer for Integral Care, and mostly it was putting up with John, just in case you were wondering, so I tease. We actually have a long-standing relationship with Central Health. We're very appreciative for the opportunity to get to speak today about just a subset of that work, but we have years and years of collaboration and partnership with Central Health and support, and very nice to meet you. So Integral Care, you want to go to the next slide? One more, there we go. It's a local mental health authority for Austin and Travis County, for those of you who don't know. We will come back for a larger presentation in a month or so when our new CEO is on board and give you a full and more detailed depth and breadth of our services and things that we've done over the past year. But we are the local mental health authority. We are a governmental entity. But we are not a taxing authority. We also have a nonprofit status. Our board is appointed by Central Health, the city, and the county. And this is a snapshot of kind of where some of our clinic work is. We're a certified community behavioral health center. We're one of the first in Texas to be certified, one of the first LMHAs to be certified under that notation. So basically, that's a focus on access to care. It's a design model around a comprehensive and coordinated effort around behavioral health care. So it's integration of substance use, primary care, and behavioral health care. And we do that work across all of these places. This is a look at where our outpatient clinics are. A good deal of our work is actually community-based, and we're quite expert at that, and we've been doing that since 1967. So that's how long we've been around here in Austin and Travis County. So you'll hear some presentation on what we've been asked to talk to you today about our medication-assisted therapy program. You heard a little bit about from Community Care, their work in that space. We actually started that program years and years ago and embedded the community care doctor in our outpatient clinic and had our addictionologists working with the primary care docs to build that program. And then it's grown in an iteration, and they've been able to take that work to their clinic in a primary care setting. I think that's what's really interesting and unique about the work that we do and the work we do with our primary care partners is our populations don't always access care at the same space, and so that no wrong door is super important, and that doesn't just mean within your own system of care, it means across systems and with agency partners, and it's very important. We could be officed right next to each other, and we have been downtown, and our clients wouldn't even walk across the street to get that primary care, but they would see that doc if the doc was in our clinic. So that's really important learning and why we're kind of building this footprint in our space so that we have that service for those clients where they want to get the service versus making them go to where we want them to go for that service. So I'll go ahead and hand off to Marlene, who's going to share on our outpatient clinic contract that we have and the medication-assisted therapy treatment. Marlene.
Hello, good afternoon. Marlene Buchanan. I'm the director of our system of care at Integral Care, so I oversee our adult behavioral health system, child and family services, housing and homeless, and substance use contracts. It's a lot, I know. So I'm going to talk to you today about our newest contract with Central Health, which is our outpatient adult service contract, adult and children's service contract. This is our behavioral health contract that you all passed the resolution for to add the $7 million to our existing service agreement. So through this contract, we're providing community and clinic-based services, including case management, skills training, rehabilitation specialist, supportive employment, supportive housing, and psychiatric services. So we have clinicians who are either qualified mental health professionals or licensed professional counselors providing services wherever the client needs it, either in the community, in the clinic, under a bridge oftentimes, and so we really follow that no wrong door, meet the clients where they're at. The services that we provide are, in this contract at least, are funded, are funds for people that have no insurance and are MAP eligible. So we've added that caveat of MAP eligible as well to try to get folks enrolled into MAP services, which was really good for us and a unique opportunity. So we began services in October of 2023. So you all passed your resolution, and we quickly hustled to get a contract together, worked really closely with the Central Health team, sometimes daily, to finalize that contract and got services up and running. Next slide, please. So this is just a snapshot of services so far, just to show you all how we are doing. So each on the left side is the funding amount, the amounts that we've spent down for the first 4 months. And then on the right side is the total number of services each month. And so you'll see October we started off really strong. We always have a little dip in November and December across all of our service delivery due to the holidays and vacations and whatnot. But then back in January, we saw the highest amount of services that we've seen through this contract. So in the center at the bottom, you will see that we've invoiced almost $2.5 million of the $7 million already. We actually submitted another invoice yesterday, so now we're over 3 million. And we have had a total of over 16,000 services, which, if you include February, is even more now. Through January, we've seen a total of, so these are services, so a client could receive multiple services. So through January, we've served over 3,000 clients with these additional funds. So we're just very appreciative that we're able to utilize these funds to serve this unique gap. I always say, and I'll end with this, I always say that grants are great and we go after lots of different funding opportunities, but oftentimes they're for exciting programs like Diversion Center and like MCOT or Mobile Crisis Outreach, but ongoing behavioral health. You know, people need to come out of the crisis and land somewhere. And it's not as exciting of a service to fund through a grant or a contract. And so just, we really are appreciative that y'all are paying attention to the ongoing behavioral health needs so we can move folks out of crisis and into ongoing services and, not have a bottleneck in services. So with that, I'll pass it over to Marissa.
Thank you, Marlene. Next slide, please. My name is Marissa Malik. I'm the Director of Crisis Services and Justice Initiatives at Integral Care. And today I'm going to be talking to you about one of our newest collaborations that we have with Central Health. It is called our Crisis Care Diversion Pilot Program. And the purpose of this program is to initiate a collaborative diversion program that leverages existing Integral Care programs and facilities to expand community services to meet unmet needs. The pilot program will be comprised of two parts, a place to go and a place to stay, which I'll go into more detail about. But the place to go would be expansion of Integral Care psychiatric emergency services, and a place to stay for folks is going to be a repurposing of our Genevieve Huron building that's located on 15th Street to be a long-term therapeutic respite program for individuals. The pilot program is a community collaborative with stakeholders that include Central Health, Integral Care, Travis County, and the City of Austin. This service agreement with Integral Care and Central Health was recently executed in February of 2024. So we are working to get those services up and running with an anticipated expected start date specifically for the expansion of PES to begin in May of 2024. And Central Health's funding through this pilot program will be specifically towards the PES part of the diversion pilot. Next slide, please. So a little bit of background on Integral Care Psychiatric Emergency Services. It's a walk-in clinic that serves individuals, adults and children that are experiencing a psychiatric crisis in Travis County. Currently, our hours of operation are Monday through Friday, 8 a.m. to 10 p.m., Saturdays and Sundays and holidays, 10 a.m. to 8 p.m. But as we all know, people don't only go into crisis during those hours. So it is a gap in our system to where individuals are accessing either emergency services through our 911 system or emergency departments when they're really needing more psychiatric urgent care that will be offered through this expansion and access through PES. So by expanding and enhancing services, this will serve as a vital resource for our community. For the pilot specifically, it will provide an opportunity for law enforcement to have a consistent place to drop off individuals experiencing a mental health crisis, or they will be deflected from an arrest if it's not appropriate. Services offered will include crisis screening and triage, crisis assessment, crisis counseling, safety planning, medical evaluation and management, as well as peer support and coordination of care to the most appropriate level of care. And coordination of care could be through any community outpatient agency, as well as our own internal crisis continuum of care through our residential and respite facilities, as well as a direct admission to this new therapeutic diversion pilot program of where people can stay. PS will accept referrals for individuals who have a history of or at risk of cycling through the criminal legal system through this pilot, emergency departments, and or homelessness. Program services will be voluntary, and the enhanced services that we will be providing through this pilot will also include 24/7 access to a medical provider for that medication and evaluation, as well as peer support services as well. Referrals are going to be received through law enforcement, emergency departments, the sobering center, justice personnel, and integral care jail liaisons who work with the criminal legal system, but also serve individuals that are justice involved. Next slide, please. The place to stay through this diversion pilot is that's our facility on 15th Street. We will be calling this part of the pilot program the Therapeutic Diversion Program, or the TDP. It is a 25-bed facility for males and females age 18 or older that offers an extended therapeutic respite care with wraparound services. This program will combine the current bridge housing model used by the City of Austin with a respite level of supportive and therapeutic services for individuals. Services offered would be intake assessments, psychiatric evaluation and medication management, therapies in multiple modalities, care coordination, peer support services, intensive case management, and discharge planning to community services, which will include wraparound care, coordinated assessments, and outreach specialists to help individuals access long-term housing with benefits and support. So an array of treatment interventions will be provided to stabilize acute psychiatric symptoms or prevent admission to a more restrictive setting. So individuals that are often frequently utilizing crisis services or that are justice involved often cycle through these emergency services and the legal system due to barriers related to unstable housing, substance use, severe mental illness, and ability to stabilize in a location. So currently we don't have a facility that provides an extended stay. So this will give individuals in our community an opportunity to stay for up to 90 days to help support that stabilization period and connection to services with integral care or through our community partners to help ensure that they're not cycling through the legal system, our crisis system, or emergency services. So that is an overview of our crisis care diversion pilot program that we're very excited to be starting. Very happy that Central Health was the first to execute the contract through this 3-year collaborative. We're currently still in negotiations with the City of Austin and Travis County through this pilot program. But again, like I said, we're very excited to begin this work because it will be a tremendous asset and resource for our community.
And I'll echo very quickly while Katie comes up that I think this is a real opportunity and a tremendous asset for the community. It's also a learning opportunity for us. There's nothing quite like this in Travis County or Austin today. And I think as we continue to work with the Travis County Sheriff and with the Commissioner's Court and their staff on what diversion programming looks like going forward, I think the earlier start that we have here is really going to help inform those conversations. So I will quickly introduce Katie, who needs no introduction. Katie Coburn is our Central Health Healthcare Finance Policy Director, and she's going to provide you an update on the opioid settlement funding.
It's so nice to be talking to you all about something other than the LPPF today. I'm here to update you all on at least a partial funding source for some of the work that you all have heard today. I'm sure you have heard in the news over many years that there is an opioid settlement initiative out there, and funding is available through that, and I want to talk you through about how much it is and how we can get it. Can we Go to the next slide, please. So just to start off with the takeaways I hope that y'all hear today, Central Health as a hospital district does and will receive periodic automatic distributions from the Texas Opioid Abatement Fund Council, which is created as part of the settlement initiative. We expect our first distribution this spring, about $3 million this time. One difference from tobacco settlement funds, which are unrestricted, is that opioid settlement funds must be used for opioid abatement purposes. So we'll talk a little bit more about that. Next slide, please. So the opioid settlement initiative is really being spearheaded by the Texas Comptroller, who created this slide with lots of small print on it. So I'm going to walk you through the high level information here. In 2021, the Texas legislature passed legislation that defined how these settlement funds would be distributed across communities. They are estimating right now, the state and the comptroller is estimating right now that Texas will, over the next 18 years, get about $1.6 billion from these settlement agreements. This is just an estimate. It could change, it could be less, it could be more, but that's the number we're working with now. And again, the comptroller's office, it provides the administration for getting these funds out. The bars you see kind of walk you through where the funds go as it meets out over time. So from that total amount, you have $1.3 billion approximately that will go into an abatement trust fund, and $244 million that the legislature is going to retain and appropriate as it sees fit for abatement purposes. Out of the trust fund amounts, there's a portion that goes to the Opioid Abatement Fund Council to distribute. That's really who we need to be paying most attention to because they will govern how the hospital district allocation goes. But you'll notice here as well that as part of that next tranche of funds, municipalities and counties also receive an automatic distribution. So City of Austin, and that's already happened. So this is sort of happening also in timing purposes too. So about this time last year, the City of Austin and Travis County received its first distribution from these funds. They each got about $1.5 million in that distribution. So what's happening now, and this spring, the rules are about to be finalized, that of the fund council's amounts to distribute, 15% of that automatically goes to hospital districts. So you see in that second to the bottom orange line, the $166 million. That is for the total, that estimate is for the total 18 years. So, but they're trying to front load the distribution to get it out early. Right now in that tranche of funding, the estimate is about $43 million. Central Health gets about 7 and a little bit more percent of that, hence the $3 million estimate, which we expect in this later this spring when the money gets out. And you all will hear about that every time we get an allocation. The board will need to approve a resolution to accept it. And then beyond that, the district funding is what we're talking about here, but the council will also be putting out grant opportunities for that rest of that $933 million. So those are other opportunities that entities like Central Health and our partners or all of us together may choose to apply for. So next slide. And then as I mentioned before, opioid settlement funds must be used for opioid abatement. It's not unrestricted funding like tobacco settlement dollars. So this is not an exhaustive list of the types of services that the funds can cover. That it is quite expansive actually, but these are some of the key ones that the funds can be used for. And you know, as we work with our strategy and with our partners, we'll figure out the best ways to use the funds we get. And you can, and that's just a reminder, that's what we get, 3 million this year, hopefully more soon. And that's it. That's it. Thank you.
All right, I get bat cleanup, and John, will you come introduce me, please? Just a quick update as to our direct practice practice of medicine as related to behavioral health and addiction disorders. I think the focal point here is no wrong door. So as we build out any environment that we build out physical health, we need to build out access to mental health. We have 2 individuals who have been hired. First is Kat Conti. The second is Ashley Trust. Kat Conti is an LCSW by training, and Ashley Trust is a psychiatrist. Both have significant experience in trauma-informed care, caring for individuals with addiction disorders, justice-involved individuals, and addiction disorders. Not sure if I said that twice. The CAT is on board now, and our behavioral health services will start in 2 weeks. Areas that we will be expanding into, transitions of care, mostly for our patients in skilled nursing facilities, into the respite environment, which I'm really excited you're about to hear more about in a second, and then throughout all of our specialty care lines. Ashley will be joining us at the beginning of May, and psychiatric services will begin probably a couple months later. We're still building out the policies, procedures, all of that basic infrastructure. And so a lot more to come. I think some of the opportunities that really exist between partners, and I think everybody that spoke really spoke to that, is the navigation between individual care centers. And so as we sit together, there is significant opportunity that exists in which if there's a patient that is being seen within central health, but they have severe mental illness, how do we smoothly transition them into an integral care environment? And so we are speaking, and the same exists for community care. So we're speaking to our partners about that navigation piece, and we'll be bringing you much more soon. And I think that ends this portion, and I think we are open for questions.
Well, that was very detailed, and we appreciate that. So does anyone have any questions? Yes, Manager Mawani.
Thanks, Chair Brinson. And if you'll forgive me, this isn't really a question, but an overarching comment on what I think would be helpful for me ongoing. And first, just, of course, really thankful for the presentation, really profound presentation we've just had with folks who've been architecting policies and practice around a very critical area of care for a long time here. So it's a privilege to be privy to the strategies that you all are sharing. And that said, given that my inclination is, of course, to defer to the profound expertise in the room, in the building, and behind our strategies, what would be helpful to me is being shepherded along both a moral and pragmatic paradigm for determining how resources ought to be routed to the particular care areas we're looking at. And to simplify it, perhaps for my benefit more than for anyone else's, if I were to look at overarching problems or concerns around health, public health and population health, and look at prevention, the sort of spectrum of prevention, intervention, and crisis intervention, sort of crisis intervention being the worst or the most sort of profound issue. And these may not be the exact terms that are used in the arenas, but I think everyone sort of follows that spectrum that I'm looking at. We see this iterated in addressing challenges like folks who are experiencing homelessness. We will have at risk of homelessness We'll have unsheltered, or we'll have sheltered homelessness. We'll have unsheltered homelessness, and then we'll have unsheltered homelessness for over 60 days and beyond, each of which represents a different degree of profundity and also a different degree of, obviously, intervention that might be required, and, of course, corresponding expense. Now, if we look at that through the lens of substance use, sort of if we can go back to the pyramid slide, that'd be great. I think it's like 7 or 8 back. Oh, it's much more than 7 or 8. It's toward the end of, yeah, 2 back from here. One more. And so this pyramid shows us 3.8% of the projected patients, experiencing severe SUD. And we see how that pyramid sort of iterates itself. And we see the same in the following diagram with mental health diagnoses that are independent of substance use, presumably. And I think the question that I see happening over and over, in my own mind as well as in the minds of so many stakeholders I hear from, is that in a world where we know we have finite resources and we're doing our best to do right communitarily, how can I see what that pyramid looks like with respect to resources? And and clearly it's not going to be an identical pyramid, or I would assume that it's not an identical pyramid. And how can the experts sort of help walk me through the moral criteria and the pragmatic criteria, the utilitarian criteria that are sort of wedded in the world of both public and population health, for me to understand and get a better sense of how and why we make those allocations? Because the questions that invariably come up, perhaps at a more simplistic level, are we cannibalizing prevention opportunities as a result of responding to crisis? And are folks who are at risk of homelessness perhaps losing, and again, this is not what my contention is, this is maybe perhaps a common question, maybe not being able to access preventive services because we are being reactive to crisis situations. And so I assume that there is a lot of thought put into that already, and so my inclination is obviously to defer. I would benefit from being taught more around how we get to where we get, and also, of course, being able to see what those pyramids might look like resource-wise.
Can I say something first? Just a question. Are you thinking in terms of homelessness, or are you thinking in terms of mental health and substance abuse?
Well,
because the reason I'm asking that is there's obviously an overlap. Right. But the answer to your question is different depending on whether you're talking about services for individuals experiencing homelessness or whether you're talking about services for housed individuals. So it's a different
I agree with you.
And I don't know what your question is.
I agree with you. And because of that overlap, I'm nervous to even delineate housed or unhoused because, again, the spectrum of housed and unhoused, those who may be sheltered homeless might be experiencing stressors or on the brink of mild to moderate, not SUD, but mental illness, etc. But to clarify, it's in both circumstances. Let's remove, for example, the experience of homelessness from the equation and discuss perhaps folks who are experiencing, maybe mild to moderate. Could we go to the other pyramid, please? The next slide forward. Mild to moderate mental health concerns. How do I know, how can we get a better sense of which resources are there to prevent that movement into potentially severe mental illness? And then, of course, the overlapping concern around substance use, where that could
out of crisis, yeah.
What's that? Yeah.
How do you keep them out of crisis?
How to keep folks out of crisis versus what we're doing to respond to crisis as well. We know recovery is a tortuous path to success, and so I just would like to be better informed on how we're doing that, whether it's in the public forum or whether it's in a spin-off or just a one-on-one instructive. But I think that that's somewhere where I have a lot to learn to be able to feel better myself about the decisions we're making, but also to be able to communicate with external stakeholders around it.
I think it's an amazing question. Obviously, the question is so deep in nature that that it's tough to answer it in its entirety. What I'd like to actually ask or point out is that there are even more challenges before getting to that level. I want to point out some of those challenges, and I think some of the opportunities that exist. If we are all analyzing the care continuum independently, we may be misusing resources, to your point, because everything is within true intent. Central health may be doing some, concentrating on areas of care differently from integral care, differently from community care. I think the opportunity that exists now and the conversations that we're having now is to talk together and to really, whether it is, mental health, and it may be specific mental health conditions, looking at a care continuum for that jointly as a system, and then determining who has the expertise in which area, and then where those funds go to that area. As long as we continue to do it independently, I think we're missing significant opportunity. And so there's a challenge and an opportunity right there. And I wanted to open it because we've got, wonderful experts in the audience to weigh in as to what their perspective is. But I just wanted to point out both the challenge and the opportunity, taking one step back.
Thanks so much. And in the interest of time, I don't feel like this is something that can be answered. I just wanted to say this is a lens that over the months and years ahead will be a helpful lens for me.
Can I suggest that I'm glad you're raising this, that maybe a follow-up at some point in the future would be, and maybe it's a retreat conversation or maybe it's another kind of conversation. I think it would be helpful to have an understanding of that continuum, and actually, to cut to the chase, to have an understanding of what you all think services need to be built at which part of the continuum and why, and how is that a collaboration with everybody else in the community. I know y'all have done some of that work. The Healthier Austin idea is doing that work around homelessness specifically, but we need to do that work around everything, really. So for the board to understand our budget and where we're putting our money, it's helpful for us to understand it's going to this on this continuum of care because we're the best resource for that, and that's going to get us the biggest bang. So I hopefully that's helpful, but I think that'd be part of a really good conversation to have.
Thank you. Madam.
Yes, Manager Jones.
Manager Valdez has her hand up.
Do you want me to go?
Yeah, I'm going to let Manager Jones go first. So.
Okay. I would just like to piggyback off of what Chair Kitchen said, but not just for this. I think a retreat would be great, but I don't think we should restrict it just to mental health and substance abuse. I think here's an opportunity for us to look at the whole healthcare picture itself. The district, public health agencies, and even maybe to a degree, the emergency medical services. So I would just think that given the limited amount of time we have today, I would encourage us to be able to look down the road to be able to have such maybe a retreat involving all of those agencies and representatives so we can get a big picture of it because they're interrelated, obviously.
Thank you. And Manager Valadez?
I agree 100% with what Manager Shannon Jones said and Chair Kitchen and Amit. Because what scared me a little bit was when I saw in one of the slide descriptions is you have thrown the substance abuse population in with the IDD population. And I'm sorry, those are two very distinct and separate populations that should not be mixed. You want to go to that screen, please? It's like throwing Gloria in with the same people that are choosing to OD or try to use fentanyl. I mean, there's some behavioral and mental health issues that the IDD population doesn't have the ability to understand and decide for themselves that they're not competent. They're not capable of making a decision. And you're throwing the populations together, and I think that's very wrong. You see where it says mental health, substance abuse disorder, or intellectual and developmental disabilities.
Thank you, Manager
That could be
Valadez.
eligibility, but there should be two distinct and separate places for them to go. And
Yes.
a comprehensive discussion of this is
Yes.
exactly what is needed.
Manager Valadez, I think we have Dawn here to address your question right now.
Thank you for the question.
Okay. But what I was, I guess, just real quickly before I'm cut off, because I'm not going to take 5 minutes to express my concerns. I would like just to echo the need for a separate meeting to have a discussion, a thorough and comprehensive discussion with the experts to talk about this and what Central Health is doing as opposed to what the other entities are doing, so that we're not duplicating services and we don't have the same populations or the same individuals benefiting from all the dollars
Yes.
in all the programs. Thank you.
Thank you, Dawn.
Thank you for the question. This particular slide is really talking about the diversion work, not the substance use or MAT type services. This is strictly jail diversion, and what we know from the community is that we do have those gaps. There's a significant number of individuals that are arrested that do have an IDD diagnosis, as
Right.
well as a behavioral health diagnosis, as well as a substance use diagnosis some of the time. And what we don't have is any place for them, and they're being incarcerated, and they stay incarcerated much longer than even those folks with just a single mental health diagnosis. So this is going to give an opportunity early on at deflection and diversion so that these individuals do not go to jail, and that we're able to connect them to ongoing services, whether it's at our clinic, with our providers, or a provider in the community. Many of the individuals with IDD do have their own private providers. It's a certain skill set. Not everyone is well-versed in how to serve this population, and some medications that you prescribe for this population, they metabolize it differently than others. So it's super
Right.
important to have some background there. But this specific project was really just about the jail diversion opportunity and to try to keep these individuals out of jail. But I don't disagree with you. There are unique and specific needs for this population. And in general, mixing these populations of folks, they need a little extra care. We do see that they have the most difficulty getting an inpatient bed, for example, from some exclusionary criteria and not being able to serve them. So we wanted to create a space that we could divert them and them not sitting in an emergency room and not going to jail.
I want to clarify something. I've been following this particular issue for about 30 to at least 30 years, not 32, 30 years. When John Vasquez was a municipal court judge, he would let me go sit in on his night court, and I was there and would witness special needs students who totally incompetent, without parents, without any adults, having someone talk to them in a language they didn't understand or couldn't even speak. Sometimes they were deaf. And there were judges themselves and the attorneys, the prosecutors, were not tapped into the AISD or the school district, whichever they may come from, system that would tell you and explain to you exactly what their existing behavioral needs, or BIPs may say, behavioral intervention.
Manager Valadez, thank you.
So
We
it goes
are
back a
moving
long,
forward.
long way.
Yes, we know. So let's move into the present.
I also want Dawn. No. This is the present, because that's still ongoing. And Dawn, what I want you to understand is that we also need to bring in those people who are responsible, which would have been MHMR or the school districts, so that they could, the diagnosticians and the people who make up the ARDs, who are responsible for writing those plans and showing what interventions are going to be appropriate, tied to the psychiatrists or psychologists who are overseeing their treatment for their behavioral and their mental health issues. Because
Point of order, Chair.
those are the children that become
Manager
the adults
Valadez,
we're dealing with right
Manager
now.
Valadez, thank you so much. Thank
I
you.
just wanted to
Yes,
say that.
Thank you.
Thank you. I hope everybody could hear what I said over you.
Yeah,
Thank
I
you.
think we could. Thank you.
I hope so. Thank you.
Manager Kitchen.
Okay, just a quick question. This is for, well, first off, thank you to everybody. This is very, very helpful. I really appreciate it. I also would invite you, if you have more information you want to send us, please send it to us. I know that this is a short amount of time, and you probably, there's a lot more going on there, community care, integral care, a lot more going on there. And so I would just invite you all to send us background slides with more information. That would be great. So my question is just, I have one question. So, and this has to do with that first slide, I think one of the first slides from a central health perspective, one of the summary slides about the services. And this is a very specific question. Does central health provide for services that are at the bridge shelters, North Bridge and South Bridge, or the marshalling yards? And I'm talking about physical health services and or behavioral health services.
We actually have a presentation immediately following this one that I think will speak to that.
Oh, all right. Sorry, I got ahead of you. Thank you.
Yes, please.
Thank you, Chair Benson. Just before we move forward, I wanted to echo my appreciation for us having this conversation. All the folks in the room have had the years, almost decades of experience coming to this moment that we're actually talking at the table together. I think your comment, Alan, is spot on. That's one of the great opportunities here, that we're actually having the conversation side by side, not duplicating efforts. I loved your question, Manager Madwani. I would add to this that just a couple points, orienting points for me. One, there is no health without mental health, whether it shows up as addictions or depression or anxiety or chest pain or shortness of breath or back pain or chronic pain. At its root, it may be mental health. Alcohol is a benzodiazepine without a prescription with worse side effects, right? So that's one. Two is we have a current system that is reflective of what we've decided to pay for, not what is needed. That is our opportunity to have this conversation and ask, and by the way, that system is enormously wasteful and results in a really irresponsible use of the public's dollar, whether it's in hospitalizations or in incarceration and so forth. So we have the opportunity to go upstream, Manager Madwani, and ask, in conversation with our patients and those who work with them, walk alongside with them, what is truly needed here to meet people where they are, to create bridges across the chasms, to catch people and help them get up on their feet, stabilize and strengthen, all of which will be tremendously high value at the top end of that pyramid. I don't know what that is yet, and I think it may take a little while for us to get on that road. This is a long-range view, but I'm not sure that anywhere in our country has truly grappled with and built what is needed. And so I look forward to that conversation. I think a retreat makes sense, but this will be just the beginning of the conversation, right? There's a lot here that results from deep distortions in how we've approached this problem as a country. And this is one of our great opportunities to move forward in this space.
Thank you so much. Yes, Manager Kitchen.
Thank you, Dr. Lee. I think that's hitting right at the questions that we may have as a board. We want to be part of that, making sure that Central Health is doing, is right at the forefront of building a system in our city that is the most cost-effective, high-quality delivery system that we can make. And we have an opportunity, to do that. And there's some understanding that we on the board can benefit, some learnings for us on the board from you as experts. And I know you all have already done a lot of the work in coming up with the health equity plan. Bring us along and help us understand so that we're all part of deciding where to put the resources so that they're the most high quality, cost effective we can do.
Yes, Manager Jones.
Just one quick comment. This year particularly is very unique. I forgot who mentioned it earlier. This is the 20th year of the creation of the district, of voting for the district. So it's a good mile marker for us to begin to reflect on where we've come from, what we've built, and where we're going. So I just want to echo those sentiment in light of those.
Thank you. I especially appreciate we need to be forward thinking. So thank you, Dr. Lee, and thank you all very much.
May I just,
One more. Yes, Dr. Lee.
I'm so sorry. Chair Kitchen, we will, absolutely. And I will add that I think the good news here is the most cost-effective system is also the most compassionate system, the most dignified system, the one where we meet people where they are and we treat them with kindness, and we ensure there are no delays, right? We do what we'd want for ourselves and our loved ones, and that will be the highest quality system. So I believe that's the opportunity here.
Thank you all very much. So we're going to move on to number 4. Receive an update on 2 of Central Health's services focused on people experiencing homelessness, including the development of additional respite care services and bridge clinical services. And again, we have Dr. Audrey Kwong, and Megan Clark will be joining Dr. Alan Shalsa.
Hi again, and it is with great excitement that I introduce Megan Clark, who's our Director of Operations, specifically for transitions of care and respite, and Dr. Audrey Kwong, who is our Director of High-Risk Populations. And I'm going to give you all space and back away from the table.
Well, thank you so much for having us. We are about to celebrate our 2nd year anniversary of medical respite, so I wanted to give you a quick update, and I know some of you may not know our program as well. So I wanted to start, next slide, with some of the sentiments of the community that inspired us for this program. Every now and then we do like to meet with Austin's Homeless Advisory Committee, and we meet with them to kind of hear what they think they need in the community. And I will never forget a woman who told me, "I have nowhere to be healthy. I have nowhere to be sick." And I that was so gut-wrenching for me because I think there's so many things we take for granted. One person also said, "I can't get my cataract surgery because I'm homeless. My wounds won't heal because I'm homeless." Meanwhile, at the hospital, we had doctors telling us, "I know this patient's going to be right back," because they're going back to the streets. And then we hear from our street medicine teams and EMS and paramedics the moral injury that they feel when they see somebody who is experiencing homelessness and they have nowhere to send them. So that is what inspired our program 2 years ago. So next slide. So a lot of people ask me, what's the difference between a shelter bed and medical respite? Because at the end of the day, it is just a bed. But with that bed is this team, a team that is navigating you, supporting you, and cheering for you, and advocating for you in a very, very confusing healthcare system. And with all of that, you get these beautiful icons that I found on the internet with wound care, hygiene, meals, meds, rest, appointments, physical therapy, help with transportation, and just someone to talk to and who will listen to you and help you. And so while this list is amazing and beautiful, I think what is tragic is that none of these things happen when you're experiencing homelessness. So next slide, I want to show you the evolution of our program over the last 2 years. So on the very top is when we started 2 years ago in March 22 with 6 months increments to now, March 2024. On the left column is 4 different categories of our staff, bed capacity, our referral sources, and our medical practice. So when we started 2 years ago, we had 1 social worker, 5 beds, we only took referrals from nursing homes, and we just coordinated our services. 6 months later, we added 5 more beds. We started taking referrals from our healthcare for the homeless colleagues at Community Care. By a year later, we were able to add a nurse, a medical assistant, community health worker. We added our second site. We have 5 beds at the Arch. So we had our second location, and then we started taking referrals from the hospitals, and that's when the floodgates opened. In the fall, we added another 5 beds at a third site, the Marshalling Yard, which has been a great partnership. We started taking referrals from specialty so we could upstream take patients who needed surgeries. And then we added our medical practice. So we started doing vital signs, wound care, glucose checks. And now in March of 2024, we have our second nurse, we have a second MA, and we've added 5 more beds at the Arch. So that's sort of the progression of our last 2 years. We've had to date over 400 referrals, and we've taken over 170 patients into our program. Next slide. So I could talk about our metrics for an hour, but I'm just going to give you the highlights. So on the right, the red is central health referrals, and the green is community care referrals. And over time, by quarter 2 in the first year, we started opening up to hospitals. So that's the blue box. And you can see that over time, referrals from Seton just grew and grew. To the most recent quarter, we have about 32% of our referrals coming from the hospital. And I think it could be greater if we allowed it and the word got out. And then by the last quarter, we've sort of been dissecting out our central health referrals into the different teams, transitions of care, care management, our nurses in the hospital. So that's why you see those different red, orange, and yellows. So that's our referrals. Next slide. So this is just looking at the last year. We took 145 patients. On the bottom left is sort of saying like what happened to our patients. And you can see across all of them, whether they decided to leave our program, whether they were administratively discharged, whether they were hospitalized, or whether they complete our program, the average length of stay is 30 days. I would say that 30 days is quite a long time to sort of get some medical appointments done, some healing, some rest. So whether they stayed or not, I think 30 days is great. And then on the right is sort of some places of where they went after they left us. A fair amount went to our residential rooming program at Fresh Start. We had some go to permanent housing, some we reconnected with family and friends, some we got to the Arch or marshalling yard. So hopefully we were able to offer them something and not have to discharge them back to the street unless they wanted to. Next slide. And this is the last metric slide, demographics. Most of our patients are male. Most of them are on average in their 50s. We have about 40% who are white, close to 19% who are black, and then Hispanic is 36%, I think. And then on the right is all the different things that we do for them while they're with us. We help them apply for IDs. We have case management, transportation, appointments. We get them a coordinated assessment. They are a bit of a captive audience, which is great, so we have some time to work with them on different things that they'd like to work on. Next slide. So some of you may remember in January we had a freeze. So after the new year, I think all of the weather reporters were unanimous that freezing temps are coming, and they did come. And what I was really happy about was since the fall, Dr. Shelsha has been telling us, like, what are we doing? We know winter comes every year. We know we're going to get freezing temps. What are we doing to prepare for that? And so over the winter, we started talking with hotels. And I remember on January 9th, we were all in a meeting, and we had spoken to our respite partners, and we had had a way to increase our capacity at each of our sites, and we also had hotels that we knew that we could use if we needed to. And during that week, we also met with our partners and said, if you find somebody, we talked to the hospital, we talked to Sunrise, Camp Esperanza. If you have somebody that needs medical respite or needs a place, please call us. And meanwhile, the city was also making their preparations, and we were working in tandem with them. And so Saturday was amazing. It was like 60 degrees, and I was like, is it really coming? And it did come on Sunday. And for the next few days, we had below freezing temps, and the highs got up to mid-20s. On Sunday, I got a call from Sunrise Church. I got a guy for you. He had been in the hospital. He has stage 4 lymphoma with metastasis to his spine, treated 2 years ago and lost to follow-up. He showed up at the hospital in December, got a biopsy, never got the results. He had some neck swelling, got discharged, and wasn't able to make it to any follow-up appointments. On January 13th, he went to the ER. He wasn't feeling well. He was diagnosed with a urinary tract infection and got discharged back to the streets. So he showed up at the church. They were able to get him into one of the community churches, but the Pastor Mark was very worried about him. So I went and saw him on the 15th, and he was very interested in medical respite. He wanted to stay at the church a couple more days while he could, and then by the 18th, when the church closed their services, we brought him over to medical respite. Within the following week, we set him up with a PCP. The next week, we got him some glasses. We called oncology. They gave him an appointment in a month. We advocated and said he really needs to be seen soon, very soon, and so we got him in within a couple days. And within a month from when we met him, he underwent his first cycle of chemo, and currently today he's in the hospital getting his second cycle of chemo. This is a great example of how many of people that we don't know about are lost in the system. Yeah. This man would have probably been still kind of flailing in the system if the winter hadn't come and he was forced to kind of come out of the woods. And so we're so glad we're able to bring him into our program. Next slide. So there's so many benefits of our program. And next slide. So I just wanted to give you an update. So in the upper left is a gentleman that I shared with you about a year ago. He was one of our first medical respite patients in October of 2022. He is a day laborer and was not taking his insulin, got an infection in his hand, got osteo, and had to get an amputation of his arm. Most patients who get discharged with an amputation have to figure out how to get to a clinic to get their prosthesis. It takes many weeks to get the prosthesis made, fitted, physical therapy. So we brought him over to respite. He stayed with us for 5 months until he was able to get his prosthesis. We got his diabetes under control. He had a sensor. We got him some glasses. But he still needed cataract surgery. But at that point, his surgery wasn't scheduled for many months away. And so we discharged him in March. And then in the fall, we found him again. And he said that he had showed up for his cataract surgery and got turned away. He showed up for his ophtho appointment and got turned away. And he didn't know why. He doesn't speak English, and he didn't know what to do. So he came to us, and he needed a couple other things, which we helped him with podiatry, and had another infection. But we were able to get him his cataract surgery. He got his right eye done in January, and he got his left eye done in February. And we will never forget when he came back and he was crying, and he said, "I can see because of you guys. I cannot thank you enough that you came to find me and help me." And I just think it's so different in a healthcare system where you have to go to people, and sometimes it's not that easy, and you get turned away. With our care, we go out looking for you, and we don't give up. And if we can't figure it out, we'll force our way and make it work. And then this last gentleman on the bottom, he came to us in the fall with stage 4 liver cancer. And sadly, 2 years ago, his liver mass was 3 centimeters. He was unhoused and had no insurance and just got lost. And when he came to us, his liver tumor was now 15 centimeters, and he had metastasized. So we were able to bring him in. He got surgery, did some chemo, and after 5 months, unfortunately, it wasn't working. And we, with the hospice team, decided that he was ready to go home. And this picture is him. He tamed a little bluebird at respite with some Frito corn chips and sunflowers. And so he made, and he always had a smile for us. He loved to read his Bible every day and just loved being with our team. And so when that decision was made, we called his family. His mom lives right outside of Lafayette, Louisiana. And this is on January 19th, we had a going home party for him where we had Popeyes fried chicken, chocolate sundaes. He left, his cousin came to pick him up on Friday. And by Monday, we had hospice services set up for him at his mom's house that was gonna be there at noon. And so sometimes we are just there for accompaniment to support people along their journey. And it is for us just a pleasure to continue to work with our patients wherever they are on that care continuum. And so there are a lot of benefits for respite that are just not physical. There's a lot of just healing of wounds, physical wounds, but also healing of hearts. Next slide.
So I get to talk about what's to come for medical respite. So Dr. Kwong mentioned our model of care now, which is really a coordinated clinical care model. So we do some basic medical care, but it's a lot of coordination with medical, mental health, and social resources within the community. So now we have an opportunity to really build a comprehensive clinical care model. So that includes on-site, not only behavioral health services, but peer support services, having on-site clinical services that include 24/7 support, as well as connection to primary care, case management, pharmacy services, and others. And so we are hoping to open a Cameron Road medical respite site. So you can see on the picture, Central Health has purchased all 3 of those buildings, and in one of those buildings will be a 50-bed medical respite site that will house dual and single occupancy rooms, and again, the services I just mentioned. So medical, pharmacy, wound care, potentially some specialty care services, and patients will stay on site for their total duration of their respite care and have access to food, of course, housing, if they need transportation, also get disability assistance, as well as outpatient pharmacy, mental health and behavioral health services, all in one place. So we are excited for what's to come. And I also will note, I think we're trying to do a good job of making sure we build this right, and that it's a good fit for our patients. And so one of those opportunities is to partner with other organizations across the country that already have great medical respite programs. So our team recently was able to take a site visit to a organization called Circle the City in Phoenix, Arizona. I'm not sure if you guys have heard of them, but they have 2 50-bed respite facilities, and they're building a 100-bed respite facility at this time. And so it was a great opportunity to talk with those team members, tour their 2 facilities, and really take back some of their best practices and hear about a lot of their lessons learned that I think we will be able to incorporate into our journey as we get started, and then really utilize them as a resource as we build out our medical respite center. So fiscal year 25, we hope to have a freestanding medical respite center. Next slide.
So as we've been on this 2-year respite journey, I think we've uncovered a lot of gaps in the system. And speaking to what we just talked about, sort of this care continuum of right now, we're really just at the tip of the iceberg of people who are desperately needing just a place to be. But what we found over the last 2 years is people are calling us from all different kinds of parts of our community, and we're realizing some of the systems of care upstream that are, not working out for our patients. And so I think we're learning a lot of, sort of the 3 patients I mentioned, what got in the way that they couldn't get care when, the cancer was smaller or when their wound was smaller. And so one idea that we've had is sort of a clearinghouse where people could come. If you're a community health paramedic and you've got somebody, what they've said is, we don't know if they're appropriate for respite. Should I take them to the hospital? Should I take them to the clinic? What if you could bring them somewhere where we could kind of check, evaluate them and see what is the most appropriate setting? Or someone who's coming out of the hospital who didn't know where to go or missed their appointment and just doesn't have a phone to figure it out or know where to go. So we're thinking about what that could look like as a continuum of respite, sort of upstream of how we can help individuals as we're trying to decide what the best environment is. And so that's very exciting, and we'll have more to share as we kind of develop those ideas. And then one thing I just wanted to answer your question, Chair Kitchen, about, you asked about the bridge shelters and marshalling yard.
Yeah.
So Community Care's mobile team right now goes to the bridge shelters and marshalling yard.
Okay.
And I've been doing a lot of this work for the last 6 years, and I've been really excited to see this coordination between, there was a cleanup of a camp that happened about a couple weeks ago, and the city of Austin let us know so that our team was at the ready during that cleanup to hand out Narcan. And as they were offered North Bridge, we were able to, help them. Many of them had wounds. Many of them we were able to start on Suboxone. So our mobile team was able to go there that day, and then subsequently for a couple more times to just make sure that they were comfortable on their Suboxone, that they had any wounds. And similarly with the marshalling yard, I think our mobile team is going there with Community Care. Central Health's respite team is on site. So there's just, I think for the first time, I'm seeing a lot of great coordination among the teams and great teamwork of trying to figure out, what we can all do together.
That's great. So it's Northbridge and Southbridge and marshalling yards, and you mentioned the Arch before. So, and I think you mentioned Sunrise also, and I'm sure there's other locations too. That's great. Thank you.
That was, is that the end of the presentation? So this is a big ask, but anybody want to delve in and ask some questions or Yes, Manager Masaita.
First of all, thank you. What you have shared and continue to share is what care should look like and what is patient-centered care is. And your humanistic, empathetic, compassionate care shines. And thank you. I know personally of, you shared a story about a patient who's progressing their cancer and at the end of being home. And that is something that I've heard multiple times from cancer patients. They just want to be home. And the thing is, it's easy said than done. It's coordinating that care for them to secure their last wishes. And I'm glad that you are listening and doing that work. It takes a big heart. And thank you for sharing their stories and for continuing to do what you do. And I hope that we will continue on supporting you and your mission of providing that humanistic and compassionate care for those who need it. Thank you.
Any other questions or comments? Yes,
Unless somebody else wants to go first. Is there anybody else?
Oh, Manager Valadez.
Just real quickly, do y'all have the demographics on the people that you're working with? The patients that you've seen? And also, where they're coming from, like you said, you've got SNFs that are recommending, you've got triage teams, you've got hospitals. If you have that information, it would be interesting to look at it and to see how each case is I guess, succeeding or being referred out to which component of what it is you're offering. I know one of the things with the amputations, with like diabetes unchecked, people who are day laborers who are not coming in, etc. It's very difficult for them. That was one of the reasons that we were pushing for a respite years ago, and I'm so grateful. I'm so happy that where Central Health has seen fit to invest in this. But I'd like to see what that demographic data looks like. Thank you.
Manager Valadez, I think that's on the metrics page, perhaps, the metrics page, it's page 87.
Okay, when I look at it, I'll look at it. But
thank you.
Does that include where they come from, where the referrals came from?
Yes.
Yes.
Okay, thank you.
Yes, thank you. Any
It
other?
may have been when I got up to go to the restroom.
Yes. Again, Manager Kitchen.
I'll be very quick in the interest of time. So I first want to say thank you, Dr. Kwong. I know you've been a persistent advocate for this, and I know others have also. We wouldn't be where we are today if you hadn't done that. So persistence, don't give up. I know you won't, because you haven't. And the other things, so I wanted to say that. And then there's a couple of pieces of information I think you can work on these for later, in the interest of time. And first off, I would like to know the estimates of what the need is. I think I'm just ecstatic that we're building a larger facility. It won't be enough. So I'd like to understand the context for it and what we estimate the need to be, so that we can, over the long term, know what we might be working towards. So that's one piece of information I like to have. The other piece goes back to why people are going back to the streets. I'd like to understand, for those that do, for those that either have to be discharged back to the streets because there's no place for them to go, or because they discharge themselves back to the streets. I'd like to know why. So I'd like to have that data. And then I would like to understand the access to housing. In other words, one of the challenges for programs like these is having access to housing so that you can then have a place for people to go. So that's a longer conversation. I'd like to have that conversation. To me, a program is not complete. A program doesn't have everything it needs if it doesn't also have some places that you can place people. So that requires partnerships in the community for the most place. But you shouldn't have to be hunting for housing for folks. Once they get into medical respite, we should have enough beds, houses, places for people to go that you know that you can discharge them there. Longer conversation. Those are the couple of things that I'd like to talk about in more detail at some point.
Thank you. Absolutely. I just want to say yes. I do want our medical respite program to be part of the care continuum of the city's housing, and that is my next platform. In Santa Clara County, where I ran a respite program previously, we were allocated 50 vouchers a year for medical respite.
Okay.
And it was amazing. And it was almost that they were already vetted. That we knew that they had stayed with their program and they would be successful and wanted housing, and I thought that, and they did very well. And so I will keep talking about that to the city because I think that is the next step.
Yeah, I think we have to have that because when you can offer someone the whole continuum of what they need, including knowing that they'll have access to housing, I think it can make a big difference. So we should talk about what it's going to take to get that, and just know that we're here to help with that.
Thank you.
Thank you.
And only because we're on the same line, I too would like, I know it's not going to be possible, but potential medical cost savings from the patients that you see. And though it's not going to be exact, because some people are just going to go out on the street and die, and I don't know how we say the cost of that, unless you could just, write that down. But as far as money cost, yes.
That's doable. I actually helped develop a formula for that.
Oh, that's wonderful.
Many years ago in my previous program.
Oh, wonderful.
By
That's
looking
wonderful.
at the DRG for their diagnosis and looking at what their Medicaid length of stay would be in the hospital.
Yes, that's lovely.
And then the bed saved, and then some fudge factor of 4 days, which.
Yeah.
Yeah.
Thank you.
So
Thank you so
we could
much.
do that.
Yes. And Manager Jones.
Just one quick comment. Are you working with faith-based organizations, particularly in communities of color, to educate and inform about respite care? Because we might know, but a lot of folks are not as aware of what respite care is and how it benefits. So I would encourage you from that point to educate, but also for the opportunity to partner with you in terms of perhaps working long-term in helping facilities or helping out in these respite locations. So just a comment.
Thank you.
Thank you so much. Thank you. All right, so now we're going to move on to number 5, receive an update on the central health dashboards associated with service level reporting for fiscal year 2024. And there's there's not going to be a presentation at this time, but there is material in your backup, and the staff are available for any questions you may have. Number 6, receive and discuss an introduction of fiscal year 2025 strategic priorities and budget development process and the calendar. Dr. Pat Lee and Monica Crowley will be presenting.
Thank you, Chair Brinson and managers. I'll take you directly to the slide that, and I'm not sure if it's in your packet or not. Maybe it's up on the, do we have a slide that says FY25 goals?
Maybe it's the first slide.
Okay. No problem. What I want to do is actually tee this up by sharing why we are considering a slightly revised timeline for budget planning. So I'll just read these bullet points off to you all and explain why. So there are 5 goals that we had in mind that result in the sort of timeline you see up there. Goal number 1 is that it really supports focus. We know how important that is, and that focus itself, folds into goal number 2, which is to promote alignment. We want to make sure that board, our management team, our county commissioners, aligned elected officials and partners, that we are clear and aligned. That folds into goal number 3, which is to really support our health equity plan. We've defined this true north pathway. We've raised the bar and set expectations of what we're going to do. We want to be able to do what we say we're going to do, and that will require that focus and alignment. Goal number 4 then is to promote transparency and equity. We really want to try and reduce surprises toward the end of the process by providing more opportunity earlier in the process to understand what are we trying to accomplish, and how would we understand the target and sort of the gap we need to close. Then, what ideas do we have to close those gaps? We can identify what's on path, given where we need to go, and what might be not on path this year. It might be an edge case, or we should do a little more work and figure out if it's on path. And then we can develop those on-path ideas, so the seed of idea, into a more robust proposal, and ideally test this out and ask ourselves, doing it this way, what makes us believe that we would get the results that we need here? And state our hypothesis, if you will. And then finally, in each of these stages, we would be getting board alignment and agreement. What are we trying to accomplish? How we know? What are the on-path ideas for development? And then, the more full and robust proposals. And then finally, we wrap the budget proposal around. By the time we get to August, September, hopefully it's very clear where we're going, and we've got a lot of alignment support. Also, doing it this way provides a basis for learning in the following year. How far or close were we to our prediction? To what would happen if we did it this way? And that will hopefully lead to our, point number 5, our growing reputation and maturity. So my understanding is that a lot of organizations do it more like this, where we start with what needs to be accomplished, the emerging strategic priorities. That is the natural place for the board to provide reflection, direction, and accountability for us, and then for us to then do that work iteratively and bring it back to you as we build toward that budget, which really is hopefully tightly aimed at what we need to do. I will add one other nuance here, which may not be on the slide itself, but it's important to state, which is that for this first year, we are envisioning sort of 2 tracks, if you will. Track 1 is the short version of that in our mind is the health equity plan. We have already said the health equity plan is on path. So things that are clearly, health equity plan planned, or critical path obstacles to health equity plan, we're not going to spend a lot of time asking, is that on path? It is. We're going to go ahead and move into the more robust development. But there are new issues that perhaps we didn't have perfect foresight when we made this plan. Nobody does. So as new issues emerge, there's a track 2. Let's talk about these emerging driving forces. Let's think about which ones we're going to focus on, because if we try to make everything a priority, then nothing will be a priority, and we actually may undermine our efforts. So let's look at the emerging threats and opportunities, lift a few of those up that are most important, and then build plans around them. So that's my sort of framing comment. And with that, I wanted to hand over to Monica Crowley, who you all know well, our illustrious strategic officer and senior counsel, to walk us through the timeline.
Thank you. Thank you, Dr. Lee. And one of the things that is good about having the strategic planning committee is that this is our first kind of preview of this concept for the development of the fiscal year 2025 strategic priorities and budget development. We will be bringing back this presentation to the Budget and Finance committee later this month. So this is, we're kind of socializing this concept with you. Now we'll be bringing this back to Budget and Finance later this month. And then also, as a part of this presentation, we wanted to start gathering information from you about some of these driving forces and factors that you see in the community that we can take back to our staff as we're developing thoughts on some of the emerging priorities and the driving forces. I think one of the things, like Pat said, is we wanted to make sure with this timeline that we're kind of sharing these discussions around emerging priorities, around driving forces early on in March, then coming back in April, discussing what those emerging priorities might be, gathering information from you, sharing information from the staff and leadership perspective, and then working forward to make sure that in every meeting we're having now, not really starting in the summer, but starting from today onward, that we're sharing what we're seeing on the staff side and then gathering information from you about what you're seeing in the community, what your thoughts are, what priorities might be important from the board perspective, so that we can move towards having more of kind of a finalization of what these priorities are by early summer. If you look on the timeline, in May 22nd, so we are proposing that instead of having strategic planning earlier in the month of May, we're asking to move strategic planning back to the same day as budget and finance in May, so that we can have more kind of internal vetting, run emerging priorities through this business case development process, and have a discussion with the board on board-sponsored. We'll have a discussion with the board around the staff-sponsored, and then we're requesting for this timeline to gather information from the board about board-sponsored priorities or recommendations by this May 22nd timeline, so that then we could take all of those recommendations through that same business case development and review process through June, bring things back to you in the month of June as Jeff and his team start going through the actual proposed budget and what, Jeff, what the forecast, the budget, and the potential tax rate. So once he starts to get that, it's not an assessment. What is it? You get the. It is the, yeah, it is the assessed rolls that go into kind of that determination of how large the budget might be, so that then as we get into July, we're actually reviewing budget resolutions, and that then we are prepared, as Dr. Lee said, for budget approval in August, and then hopefully getting Commissioner's Court approval early in September. And as you notice, I just want to make sure that this doesn't go without saying, because this always, that's our foundation, making sure that there is public involvement throughout this process is also key to the process.
I wanted to add that I had meant to actually begin by acknowledging that much of the wisdom that you see in this timeline, is from members of the board who've shared your thoughts with me individually, recommendations. So I hope we didn't do too poor of a job of pulling that together into a visual. This is a first draft. It's not a complete departure from what we've done before, but it is a little different, and we expect that it will evolve and hopefully improve as we get better and better at this year to year. As I shared with our team internally, year one might be a little bit bumpy. Hopefully we'll learn a lot. Maybe it'll go great. We can always hope, but I managing expectations, we won't get this all right because we're sort of learning as we go. Monica mentioned this, but I'll just sort of share this sort of March to May period. If we imagine, this is sort of the period for us to do this environmental scan together, identify the emerging opportunities and threats, prioritize those emerging opportunities and threats together, and then propose the seed of the ideas that will allow us to mitigate the threats or capture the opportunities. It goes without saying, but I want to say it. We welcome board manager recommendations and ideas, both for which threats and opportunities should be prioritized and how we might go about closing some of those gaps. And by extension, I think we welcome recommendations from the county and the city. You know, it is this body's job, the board's job, to decide what are the emerging opportunities and threats, but we can be in listening and conversation with our colleagues across the county and the city, because I suspect what we will land on for emerging threats and opportunities will not be unique to us. They will be in this environment, and we likely will have quite a bit of head nodding and alignment around, yeah, that is where we need to focus. So hopefully this kind of conversation is active, but it is in this season, right? There's a season for planting, a season for et cetera, right? So this is sort of the season for planting these ideas. And then we have time then to mature these ideas through a robust process, develop a business case, confirm, wrap the budget around it, and then hopefully by the time we get into the last lap in August, September, you know, we're all pretty clear, and we're all feeling pretty good. And I mean, us here and our key partners, you know, at the county and the city who we're aligned with around these priorities. So that's some of the idea here, giving a seasonality, if you will, to the budget cycle. So with that, I think we'd love to open up for comments and questions from all of you. Thank you.
Thank you. I'll comment first. I'm thrilled with this. I'm very happy to get the budget and the strategic planning to be a little more intertwined, but also reflective of what the other needs, instead of separating those two things out so much. And I think it's important for the board to be able to defend if needed, or at least to be very excited about things that we're doing within the community, and defend or not the things that we plan on doing, and so that if we're asked, we can all of us say, we have decided this and this is why, and we're putting $3 more million or whatever it is, so that it sounds like we really are all one, which I think is so important. So does anyone have any questions or comments? Yes, Manager Kitchen.
Okay, and thank you for I concur with what you just said. I think that's important. So I just have some sort of nuts and bolts questions to make sure I'm understanding, and it may be that you're still thinking through this, and that's fine if you are. But so it talks about sharing emerging priorities, and it's got that in the month of March, and then it has present emerging priorities for board approval in April. So is the thinking that we would use the March 27th meeting to talk about emerging priorities, and then in April there'd be board approval? Is that what that represents?
I think I would invite, Chair Brinson, Chair Kitchen, your input on the best way to gather that feedback. I'll share as an executive team, we have done some preliminary work with Monica's excellent team facilitating. We've allocated part of our executive meeting to begin this process of listening to each other's environmental scan. So we have an initial version, but I'm very curious to hear, your version, right? And then we'll bring these together. And there's we've got a couple pages with each line reflecting a significant threat or opportunity. And we'd love to hear, your thoughts as well, and bring these together. And hopefully we'll have a pretty robust, sense of the horizon line, and come to some alignment around that. I'm
thinking, I'm sorry, go ahead.
I guess I think just building on what Pat said, I think kind of our thought was, but it's what your preference is, and maybe we top-lined this maybe a little bit confusingly. I think we were thinking in March that we would gather information about that environmental scan and about the the forces that might drive emerging priorities.
Okay.
And then discuss potential emerging priorities in April.
Okay.
And I think a good question that I think Pat was raising, would you prefer to receive information about what the staff's thoughts were on kind of these driving forces, or would you rather share information with us about what your thoughts are on driving forces, and then we could kind of incorporate them and bring them back?
Here's my suggestion, and see what my colleagues think. For me personally, I'd like to be able to react to what you all identify as emerging priorities, because it helps me think, and I can just say, yeah, and then I can say, well, have you thought about X? If I'm just, if I'm just reacting and I don't have what y'all's thinking is to react to, that's a little harder. Now, I don't know how y'all think. I don't know if my colleagues agree with that or not.
I look at it sort of in 25 and 26. We're actually beginning the 25 planning.
Okay.
There are, in my view, there's an opportunity we've talked about getting our vision, the leadership vision, so that we can incorporate with other players in the community. We won't be able to do that by 25, but in 26 we can. So for the 25 efforts, I think we should take from the staff, and then we react to that. That's my thinking.
Does that make sense to you guys?
That makes sense to me.
Okay, so we will need a time to do that. We're at kind of, so that means, we can do that on the March 27th, and then we can also do it in April to make it an iterative process so that you all can present what y'all are seeing. We can react to it. And I like the way you talked about that, Shannon, in terms of the multi-year thinking about it and the broader thinking about collaborating with others, and that'll be part of, that's an emerging priority that we'll need to talk about. So, yeah, so does that make sense? Does that help? I don't think that I don't know that the board has to approve the emerging in terms of voting on it. We could think about that a little bit more. We definitely need to have that conversation in March. And then we can think about, well, does the board want to actually vote on the emerging priorities, or we just want to see you put that in with your proposed strategic priorities? But I'd want to know what the rest of we can think about that part, whether we want to actually vote on that or not. So.
Well, and I agree. I think part of this is we're trying to get the board sort of oiled up and ready to go on, so that it's a smooth process of our understanding of how this this will drive perhaps some of the things we choose to do on this budget by thinking ahead to what we think we will need in the future. So that would be my thought on it.
And then the other thing I would just say is the health equity plan is something that we voted on, but that doesn't mean that we remember all that 100 and something projects. 150 projects. It also doesn't mean that we as a board, and I'm just speaking for myself, I can't tell you that I either understand or agree with the prioritization of those projects. Because I don't feel like, and that may have happened before my time, but I don't feel like that was a board exercise.
It didn't happen.
I feel like that was a staff exercise, which I think it's good. I think it was done well. I'm just telling you that it wasn't like we had a board retreat where we went around and all said our priorities or anything like that. It wasn't that. Yeah. So we need to have that conversation again about the health equity plan, so we all just understand what we're talking about.
Well, and I do just want to remind everyone that really came out of the health equity plan, because it was seen from people's view who had done
Yeah.
what we were trying to do. And so it's not looking at what they felt was most important. I think it was more like what the community needs are going to be
Yeah.
to get us an organization that rolls well and is very inclusive and covers the whole city. So, I'm not sure. So I don't feel like we can, say like, I think it was more just to get us going in a quick way.
Yeah, and I'm thinking it's like of 150 projects, the source for those projects was very well done, I think. In terms of working with the community, building off a need, and all of that. But whether project number 1 versus project number 2 should be first is not something that I felt like we had a lot of conversation about. That's all I know. So.
Sure. I think these points are really well taken. And I think as we bring these forward, we're prizing the key priorities that are slotted for the next 12 to 18 months and why is really important. I'll amplify what you shared, Dr. Brinson, that we started with the moderate and significant gaps based on the community health needs assessment, and then we built into trying to close those gaps. And actually, the sequencing of what you're hearing about from the staff, the headline there is, this is the health equity plan. So transitions to care, respite care, right, building out substance use and mental health services. This is where we started, right? So we started right in the place where it hurts, right where our patients fall through the gaps. I think that is, if I can be biased for a moment, that's not the way that every health system starts. I love the fact that that's where we started because we understand that that's where it hurts. That's where our patients get lost. And I was at Heritage Park Skilled Nursing Facility just today. I was told that 95% of the patients that we're caring for there are homeless or experiencing homelessness. These issues that Dr. Kwong was speaking to and that our team is speaking to, this is what we do, right? These are the patients who, before we started the work, the team there said, well, it's just a matter of 3 to 4 weeks after we discharge them, we know we're going to see you back. Right? And the same patients would cycle back through the ED hospital and back to the SNF. And now that's not happening. And that's just in the last few months. We're just getting started. So we will, lift up those track 1 priorities. But at first glance, I think I am really happy to see what we slotted in first. It is building up from our history, our unique way that we're going to build a truly high value, compassionate, and wise health system. And there's room for maneuvering, right? As things emerge, we're realizing, we need a little more of this, we need a little less of that. We're making all kinds of adjustments, and we can make some of that visible to y'all as well, so you can see how we are, adjusting, course correcting in flight for those thunderclouds that are on the horizon. So, but yeah, I think it's a great point, and I appreciate this conversation.
No, and thank you so much. And I would just say for the nuts and bolts piece of it, that is where we are starting with our discussions. There are, like, as Pat said, there are the 2 tracks that Dr. Lee had brought up. There's this more driving forces, emerging priorities, and then there's a review of here's what we laid out. Here's what we said we would do in the healthcare equity plan, because to be perfectly honest, not everybody on the staff that is in the teams can remember all of the healthcare equity plan projects.
There was a lot of
and
them.
so we're reviewing, this is what we set out to do in 2024. Okay. This is where we are. This is what we were looking at for doing in 2025, 2026. Here's how we're developing the track 1 business cases that, the way that we had done this in the past would have become the proposed strategic priorities off the bat. I think having this ability, instead of waiting to May, coming back with that kind of, some of the managers who have been here a while might remember the 4-hour presentation where we would historically go through, here's everything that we had done in the past year and kind of where we are, and then the proposed strategic priorities that was kind of a kickoff to budget season. I think I'm excited about having this opportunity to have these conversations both internally and with you managers in these multiple forums and with the community much earlier on and throughout this process. So thank you.
And Manager Valadez.
Thank you, Cynthia and Ann. Y'all stated exactly what needed to happen, I think, very well, and that is that we need to review what should be the priorities, at least according to the board. But that would be with the board having gone through the process of staff explaining to us what was the justification for these priorities. You know, we saw where they came from. Oh, this was a forum. You know, this is where the issue was discussed. But where it falls with respect to the prioritization of the budget strategies and the implementation of the equity plan are different. Also, the business plan development and the monies. I would want to know where the money is coming from. Is it coming from the initiative pot? Is it coming from the contingency reserve pot? Is it coming from our tax dollar pot? Is it coming from APH? Is it coming from Integral Care? You know, because they're going to be contributing. If this is a collaborative process, we're not duplicating services. We're not duplicating people. One person getting pots from monies from one entity getting monies from everywhere, then that's going to take a little bit of time to analyze. It shouldn't take much, but that's going to also depend on what questions we ask of those contractors submitting their paperwork. So if we learn to ask them, who else are you getting money from? And are you getting money for doing the same thing that you're asking for Central Health to fund you? You know, all those things are very important and that we need to take into consideration as we develop the priorities and see whether or not this fits for this fiscal year or next fiscal year, like Shannon said, or the following fiscal year. So, thank you.
Yes,
that's all I want to say.
Manager Jones.
I would just encourage us to begin to look at the timeline that we've talked about multiple years and set up a strategy by which we reach out to those policy-making bodies to say, we as the healthcare district believe we need a retreat to look at health in our community and develop a strategy to do that in anticipation of FY26 so that as we go into this process for FY26, we will have not only what we have considered, but also some of the thinking that may have come from the other agencies as well, because this year we don't have enough time to do it as we're underway. But as we look to 26 and 27 and future, that we inculcate in terms of our process, not just the budget, but the strategic process, what else is going on around us.
Yes, it's excellent. So thank you very much. Anybody else have any?
I'm sorry, Dr. Brinson.
Yes.
I also forgot that I had asked Ann to put expanding MAP and MAP basic services in our community, and what is the bottom line cost for that? What's the dollar cost for that? And what if we're looking at eligibility, because we're the ones that determine what that eligibility criteria will be. So that to me should really be first and foremost, because that's what we're supposed to be doing is expanding and providing services to our MAP population. But if we still have 200,000 people that don't have access to services and are uninsured, well, then, you know, we need to close that gap. Thank you.
Yeah, so I'm hearing that. I know that the revised document for reporting back to us has that item on it, but and I was thinking that looked fine, but in light of what Manager Valadez is pointing out, we probably need to have that conversation as part of the budget process, which might be earlier than where it is on this. I think y'all had it down for June. I'm not sure, but if we want to talk about this as part of the budget process, which we would need to because there's probably a dollar impact, then we probably need to back that one up earlier so we can have that conversation, because I think what I'm hearing from Manager Valadez is that we need to have a conversation about that, and there's probably a dollar component. So I would put that on the table as a emerging priority for discussion.
Yes, or perhaps we should consider putting that discussion into the next strategic planning committee or something if we
Yeah.
have time.
Yeah, we should.
Yes, Perla, I don't know if that's
Because if it is something that is feasible to do, that we've overcome any legal barriers, and it's something the board wants to do, and it's alignment with the staff, then we need to know what it's going to cost.
right, because
Yeah.
there must be a reason why we haven't done it yet. So I would like to hear what is it that holds us back.
We do that sooner, maybe.
Yes, and that will be a closed session item that
Okay,
we
that's
will
fine.
bring in additional outside counsel. to
So maybe March or
participate in as well.
April, maybe, just so we don't move, just so we do it before we're done with the budget conversations.
Yep, absolutely.
Okay.
Could I ask that we ask staff to organize and develop some kind of anniversary ceremony of 20 years of the district? I know the
Yes, I
election
bet
will
you
be
they're
in
thinking
November.
about that. What do y'all think?
So,
I'm so
election-
sad Ted's not here right now.
Yeah.
because-
well, I'm putting it out now here
Yeah.
in March so that we have November when the election actually occurred, as I recall.
Yeah.
So I think that, and in light of what we were saying earlier, this is opportunity to transition in terms of what we're doing, the creation of this, with the other players who have been here longer than the district has.
And the last 20 years and the next 20 years or something.
Yeah,
so
we will absolutely do that, Manager Jones. I believe May is the anniversary of the election, and August might be the anniversary of the first board meeting.
For some reason I thought it was, okay.
I may have that wrong, but that was what I understood.
Oh, that may be true. I'm just
And I know that our team is actively planning, multiple events and outreaches. And actually, we had all staff on Monday this week that we're hoping to share with you all, shortly as well, so you can see a bit about how we're beginning that conversation with our team. And this is the year. I'll headline it to say, this is the year we change the narrative around who we are, what we do, where we're going, how everyone sees us, and the role that we play, anchoring, this public system of care. And we are standing up to do that in this 20th anniversary year with a unified brand and a strong one trunk and many branches. So I look forward to your thoughts as we share that all stuff with you and as we plan this momentous year.
A follow-up on that?
Yes, Cynthia? Yes?
If we could, Madam Chair, if you could look at the original board members and those initial actions that were taken historically, and compile that. I know that's documented, so it's nobody's reinventing the wheel. Document that, put it together like in a little anniversary publication, and start with that. I think that's something to add also. I always like, even though we may not always agree with what they did, I think it's good to honor those people who were the first.
Agreed.
And they were the first
Yes.
to our board, and they were responsible for originally setting the path for where we inherited those, when we get on the board individually, where we inherited Central Health from and are now going to. So.
Right. All righty. So, last but not least, yes, can we confirm the next Strategic Planning Committee meeting, date, time, and location? Our next Central Health Strategic Planning Committee meeting is tentatively scheduled on Wednesday, April the 10th, 2024, at 1 p.m. at the Central Health Administrative Offices, 1111 East Cesar Chavez Street, Austin, Texas, 78702. And at this time, I am ready to accept a motion for adjournment. Manager Jones has put forward the motion for adjournment, and Manager Kitchen has seconded. So can we have a vote, please?
Aye.
Okay. Thank you so much.